We also have the option to spatulate a vessel. So I'll go through kind of what that looks like, but you can put a small cut in one or two sides of the smaller vessel to be able to splay that open. And basically, your goal is to increase the diameter of the smaller vessel. An oblique cut is also an option. We'll go through that as an example. And then fish mouth is essentially an extension of the spatulation technique, where instead of doing one cut on one of the sides of the vessel, you actually do two and then open it up some more. We also have an option to close down the larger vessel, and I think that this is a good technique, especially in situations like head and neck microsurgery, where it is very common to have significant size mismatch of your recipient vessel and your donor vessel. And then also, I think just always thinking about whether end to side is actually a better option or potentially using a vein graft if that's a better option. Now, that being said, vein grafts often have significant size mismatch between arteries, and so that's just one thing to be mindful of. So what do we mean when we say spatulate the smaller vessel? Well, this is an example of how that works, and I think this is kind of a very overly simplified diagram, but you can see where you make a small cut in the smaller vessel. Your first stitch is at that apex of the triangle of the smaller vessel, and then you close down the rest as if they both have the same diameter. I think just important to be mindful of how you can get an intimal flap when you make that cut in the smaller vessel, and just making sure that you really have nice 90-degree bites and making sure you're inverting the edges to the best of your ability. This is an example of fish mouth. There's examples of this in the literature a time and time again of different ways by which this can be accomplished. Now, I think that more recently with flow dynamics, and we have a better understanding of how this can be problematic. Actually, the flow can really have stasis at the smaller vessel, and then when you go to the bigger vessel, it can lead to turbulence. So I personally don't do this, but I would be interested if anyone else wants to chime in about this technique. The oblique or beveled cut is something that can be very, very helpful, and I'll show a video of this giving an example, and really works in many different types of anastomoses in different parts of the body. I think that just conceptually, it's geometry. With the oblique cut, you make the diameter of the vessel larger, and then you keep the same size of the larger vessel. So here's a video demonstration of that. We don't have audio on this, but this is a blue blood chicken thigh model. It is showing how we can make an oblique cut. I really like this because you can lay, when possible, laying it out next to the larger vessel to try to figure out how, smaller one, sorry, how that needs to be done. You can see that the only thing that is important to be mindful of, in my opinion, is potential for kinking, especially when you're using this oblique cut. You don't want it to be so oblique that it's going to just like create this sharp angle, and be mindful. I think the suturing itself is a relatively easy part, but the lie of the pedicle and how you arrange the tissues prior to closing, I think is very important. And I do think when you use these techniques, especially this one, then you can be more susceptible to kinking or twisting. And then sets up this one, and then finishes the rest on the front wall and the back wall. Okay. We also have the option to close down one side. Well, what do we mean by that? I think this diagram is helpful because it conceptually shows what you're trying to do. I think that this exact way of doing it is potentially very problematic, because if you think about it, you have a lot of flow coming down through the larger vessel, and if you just have this 90-degree stop, you potentially have risk for flow issues at that, like down in the right hand corner right here. So while I think this is a good diagram to show what you're trying to do, I think a better way is to do an oblique cut. So you have the larger vessel, you make an oblique cut and then taper off the edge. I think that at least physics or conceptually, I think it helps with the flow. I think this is a kind of extension of that technique, and it shows that the differences between mouth technique on the left and the tapering technique, which is an example of it shown on the right, is better in terms of the flow. Where the fish mouth technique, you have this like very abrupt small to large, whereas with tapering, you're having that be more gradual, which I think is relevant. Lastly, this I think there's going to be
One side of the proximal radial artery interposition graft was cut and sutured together as a semi-blind end using two interrupted 9-0 neurons, jeweler forceps, and tenotomy scissors. The diameter of the radial artery opening at this end now approximates the diameter of the superficial temporal artery at its trunk. Next, interrupted 9-0 neuron suture was used to complete the end-to-end anastomosis between the cut end of the proximal superficial temporal artery trunk and the proximal end of the radial artery interposition graft. Use of 8 to 10 interrupted suture knots allows good approximation between vessels.
So you can see there the beveled closing down on one side as opposed to the abrupt 90-degree angle. And that this is a strategy that I do think is very useful in significant size mismatch.
Position graft in this.
I think that's all I have. I'd love to have a discussion if people have any questions. Yes. I think it totally depends on where you are in the body, I guess, and if endocide is even possible. I think when you can do end to end, I think there's definitely pros of that. So, like for the lower extremity, for example, but I've had plenty of circumstances where I go endocide, and I think that that is a good option. So, I guess I don't have an exact answer for you. Yeah, because I think lower extremity is more favorable for doing end to side, just in general. Whereas, I don't do a lot of head and neck micro, so if anyone else wants to chime in, but I think that that may be an example where you're really more apt to deal with larger size mismatch and then go into side.
Jackie, excellent. Thank you. So I guess one question I have is, and be good to hear from our other instructors, is when do you make that decision to move from something like spatulation or fish mouthing to that tapered technique where you, is it like 2 to 1 or what, is there any rule that you follow?
I think it's like over 3 to 1. I think less than 2 to 1 you can accomplish with the oblique or the spatulation, is what I kind of understand.
Any opinions?
Selecting a small enough vein is key, not using the saphenous. Yeah, yeah. Or forearm. Yeah. Right.
Any other questions?
Wonderful. Thank you all so much.
Jackie. Okay, our next speaker, Angela, thank you so much for coming from Emory. Angela's a nationally known educator and microsurgeon and really, really incredible person. So thank you very much for coming. Her Instagram handle, if you're interested, is Chengster.
79.
Chengster 79. There's
Which now dates
78
me
others.
officially. No. But in case you were wondering how old I am, that gives you a hint. That was when you didn't realize people would ever look at your handle, right? It's an extrapolation from my email address for Yahoo, which also dates me. You're like, you have a Yahoo account? Anyway, so thank you. So I gave this lecture last year, so I apologize to anyone who's hearing it for the second time, but I guess I did okay because I got it again. And my residents were like, how can you talk about the coupler for 30 minutes? I was like, you're about to find out. So I think, raise of hands, who's used a coupler before? Right. I think the majority of us are pretty familiar with this. Most of us love this. As our previous speaker just said, it's great for size mismatch. So I'm going to just talk a little bit about the history of it, and then some kind of things that maybe we don't pay attention to, because I think it's very easy for the residents to look at a coupler and be like, oh, well, that's the boring thing. And there's not much to it. But in 12 years of practice, I've seen a lot of creative ways to sabotage the coupler. And when things go wrong with the coupler, you start crying because then your vein is really short, and then you shorten it again, and now your artery's kinked, and now you have to redo your artery. So a lot of this is staying out of trouble. All right, so the coupler. For any medical students out there who think like they're never going to do anything meaningful, it was actually originally invented by a medical student. So John Holt in 1960 was given a task by his chief, who said, "Oh yeah, go figure something out, whatever, go away," and said, "Can you figure out how to put vessels together?" And so he went to the lab and designed this very rudimentary ring concept with pins. And if you look at this, you go, "This is pretty much what a coupler looks like." It hasn't really changed in the last 60 plus years. Shockingly, he didn't know this became a commercial product. A couple years ago, the Microsurgery, American Society of Reconstructive Microsurgery hunted him down and said, and found he's an retired ENT surgeon now, but he had invented this and nothing happened to this project. And I think this is where today's society is much more interested in pushing your product to completion, which is into patient care, not just, dying in the lab, because this is what this happened. So a company came along and, sorry, I should say, a Japanese surgeon also, of course, concurrently developed, a similar system. So great minds think alike, right? And again, nothing really happened. And then nothing happened for 20 plus years, and another system was developed. Again, things are just dying in the lab, not getting published. And it took until the 90s before 3M, big company, came by and said, oh, why don't we find a way to apply these rings, right? And that's that stick we are all familiar with the little butterfly mechanism now. So now this is owned by Gem, who is here, and you guys should get a chance to play with this. But yeah, that ENT probably could have retired a lot sooner if he knew, right? He didn't reap any benefits of this. So here's where we came from, and here's where we are today, and it really is the exact same mechanism. Nothing much has changed. What has changed is that we now have the stick, right? So it is a mirror image polyethylene ring. It is a little bit different. It's not a total mirror because the holes are a little offset from the pins, right? It is packaged, if you haven't looked at it, in this little white thing with an arrow on it, which is very important for your tech who's never loaded it. It's arrow towards arrow. And yet they'll still get it wrong. Before you even use it, you should check your coupler and make sure it has a smooth action. If it does not, if it jumps, if it locks, it's likely got some debris in it. You just need to either shoot some heparinized saline, dunk it in, I don't recommend using lube. It's not necessary, but usually just that'll dislodge it. So again, arrow towards arrow, and you should hear a very loud click. If you don't hear a loud click, when you haven't loaded it properly. And so that means it hasn't engaged fully. All right, so if you haven't looked at it or noticed it before, it has multiple colors. And so it's color coded based on sizes. And most of us who are doing free flaps are going to be using what I call Christmas colors. So as soon as the nurses, the circulator's holding it up, is this the right size? If I'm seeing something purple or orange, I'm like, no, 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 unless I'm doing a weird fibula. That's huge. But you should know what sizes, and you should verify it before they open the package. These things are several $100s. So if you're opening multiple couplers for a case, that's a significant cost. If you're doing hand, you may use the smaller ones, 1 and 1.5, but generally otherwise I would avoid using a 1.5 or smaller coupler for a flap. It's probably not enough outflow. So you could use that for a secondary outflow, like if you're doing a deep flap and you have a second VC that you're gonna hook up, but if you're only hooking up a 1.5 on a flap, that may be a problem, unless it's a teeny tiny cute little skip flap. There are actually different numbers of rings depending on the, different number of spears depending on the size. And the actual ring isn't an actual ring. So if you look carefully and open up 2 different sizes today, the smaller ones, the ones in the 1.5, you'll see are true circles, have 6 prongs. And then the larger ones that most of us use, excuse me, are actually slightly ellipsoid. And if you can see in this picture, does my mouse show up? There's this little groove here, and that's what fits into the actual coupler piece, and that's the only thing holding it in position. So that is why you also never want to hold your coupler very vertical and pull up. Your rings will just slide out. And then you're really struggling because you've got to put the ring exactly back into position without damaging your vessel that's already on the ring. So try to avoid doing. All right, so I think most of us know this. The data is very clear. Couplers are much better than hand-sewn anastomoses in general, especially with patency. You have a mechanical mechanism now holding your anastomosis open versus anything, a hand-sewn anastomosis that can be compressible. So there's also nothing in the intima, right? So you're getting good intima to intima approximation without any suture, anything inside to cause thrombosis. If you do this correctly, this is a very quick thing. This can be less than 10 minutes. You get lovely eversion of the vessels, and this is really easy to do for even the most beginning learner. Disadvantages, there are people who have tried to use this on an artery, but the main problem is if you have a very stiff or thick artery, it's difficult to evert because of the media layer, and then also it doesn't handle a thick mismatch as well because it's not as an artery is not as dilatable as we just talked about. So, okay. So failure rate is about 2 to 10% of a hand-sewn venous anastomosis. It's as low as 0 to 3% on the coupler because it's probably less operator dependent. So if anybody, I trained in the day where my attendings made me hand-sewn every venous anastomosis. And you're like, why? And they said, well, when the coupler is not available, broken, or you have too small of a space, you're gonna need to know how to hand sew. You can learn how to use a coupler in 10 minutes. And it's sort of true. I've had to do 2 hand-sewn anastomoses in my 12 years, and it's just because I couldn't get a coupler in that space. It was so short, the pedicle in the window. And I have learned to use a coupler, and I've learned what not to use when using a coupler. Like I said, it is expensive. So it's about $1,200 per device and $150 per coupler compared to $50 for a suture. But you save 30 minutes in the OR, right? And that is overall cheaper than the cost of this device. And then people actually studied this. The coupled veins are stronger than a sutured vein. All right, so the technique is pretty simple. Somebody yesterday had referred to this device here in the bottom left, which is the Jesse Selberg dilator. We were talking yesterday and with the reps, I was like, oh, it'd be so great if they made this and color coded it to the coupler, right? Then like you would just like, okay, I need a green coupler. But you want to, same way, clean your vessels, inspect it and irrigate it with heparin, then gently dilate it if needed. And then this is Sam's quote, avoid the temptation to upsize. We all agree, and I think Dr. Israel said too, go with the smaller size. When you go too big, you're going to tear that vein trying to get it onto those prongs and just regret that. So you always size just the smaller one. If they're the same size, it doesn't matter. But often the residents are like sizing the pedicle, and I'm like, you don't need to size the pedicle. The pedicle's huge. We need to size the internal mammary because that's the small side. All right, so technique, pretty simple. Most of the times, this is actually designed for a single surgeon use. Most of the times, I have a learner with me, and so I ask my learner, do you want to hold the coupler or do you want to be the loader? But this is designed to be used as one person. So I'm holding the device in my non-dominant hand. I'm holding it flat and perpendicular. And you always want to start with your mobile side. So that could be your recipient side or that could be your flap side, depending on what you're doing, because you want to bring the mobile vessel to the more fixed vessel. If you put your coupler on the more fixed side first, now you're struggling because you can't really move your coupler and you have to be really still. You're going to take either 2 jewelers or that the coupler forceps and just gently pull your vessels through the ring. You don't need to pull a ton up. You just need enough to get a solid bite on your pins. If you pull too much up, you're just going to create this like bunchy tissue that's just going to occlude your lumen. There's two kind of approaches to how you load the pins, and I think it depends on how big the vessel is. If your vessel is bigger than your ring, because you're on the bigger side, you can't do what we call divide and conquer, which is doing pins opposite of each other to really distribute that pleating. But if you're kind of tight and you're on the smaller side, you may go pin to pin to pin to kind of maximize that stretch to get it all the way around. There's no right or wrong way. It's just to doing it correctly. You just need enough to pull over the prong. You don't want a ton, right? Because if you put a ton on there, you're going to lose length. So usually my assistant will pull the vessel through and I'll take the coupler forceps, which is that thing that looks a little angled with a hole, and I'll punch it onto the peg. I think one of the key things is also when you punch it onto the peg, you then release. Otherwise, when you come off, you're going to pull it back off of the peg. And then you're going to repeat for the other side. We talked about not holding it too vertically. Same thing, lots of irrigating with heparin, always checking, making sure you're not twisted. And then once you have everything on, you're going to just spin the end of it clockwise. It says close on the handle if you're not sure. Sometimes this will disengage when you hit the end, and sometimes it'll get stuck. I was talking to somebody yesterday, and you can get tissue stuck in kind of the butterfly crotch there. And so if the ring didn't fall out, sometimes you can just take a dilator or jewel or whatever you have in your hand and just knock it loose. But if it doesn't easily knock loose, just reopen it and disengage it, and that tissue will fall out. You do not want to take a hemostat and try to pull it out of there. It should fall out. So also, it's very tempting once you get it all the way down to just be like, yeah, you're done, and just rip your hand out. If it didn't disengage, you're going to yank your anastomosis. So you stay in position until you see the rings disengage. The rings disengage by the little pin that's in the center right here. So you have to also make sure this is not damaged. If this is bent, it will not disengage the ring, and instead, because it actually fits into this teeny groove right here, it will hit the black part of the butterfly, and then it'll really torque your anastomosis, and it'll shred it. So anyways, so tips for sex. Similarly, this was discussed yesterday. Some people will mark with a pen little dots to keep the orientation. You don't need to over clean these vessels because you're not doing an anastomosis. You want to pull fully through the ring, but not too far. And you want to push down onto the pin, like I said, and then release before coming it off. Last thing is consider using a half a size smaller, right, if you're struggling. So if you are just not able to get it onto the pin correctly, rather than continue to struggle, I'll just ask for a smaller coupler. And this is usually for radiated vessels that may look fine at first, but then you start to go pull them, and they're actually kind of fibrotic and don't stretch very well. How many people use the flow coupler? I think most of us have either love it or hate it, and it's come a long way. So the flow coupler, for anyone who's not familiar, is a implantable Doppler merged with your regular coupler. So it has the advantage of giving you an immediate signal that you can check for patency. However, when it first came out, the cord was really stiff, and they've gotten better about it, and it's a little bit better now, but it's in a fixed position. So if you do your coupler in your anastomosis, and then you put the flap into position afterwards, sometimes it'll cause a little kink or a twist if the wire's not laying in the right position. So it's just like one more thing to kind of have to pay attention to if you're using this. But it's great because as soon as you're done, you have a nice signal to the end of the case to know your flap's okay. It's a little bit more expensive, but it's not any different than if you had the Cook Doppler and the coupler. So here's just one in position. Most people remove this after 5 to 7 days. You just kind of gently tug on the wire and it disengages from the coupler. And according to this, 70% continue to function properly throughout the hospital course. And I think this is why there's a love-hate with the implantable Dopplers in general, because you get a lot of phone calls. Patient coughs, signal went away. Patient moves, signal went away. Do you take the flap back, or is it just the machine being temperamental? Last couple of things about the coupler take-home points. So this is when you can't use it. And so one of my cases I could not use it was STA for a latissimus to the scalp, where my resident accidentally fired the clip on the pedicle, thinking it was the serratus branch. So then I had to dig my thoracodorsal out for a centimeter in the flap. So now I had a centimeter pedicle and a teeny tiny STA, STV, and no room to put in a coupler. It's also great, we talked about this is a great way for a size mismatch. If you're hand sewing, you're going to end up kind of with this pleated look on the bigger side, but this makes it perfectly easy. It is overall much easier, overall much faster, makes the hospital happy when you save them money. And then higher patency leads to better night's sleep for me. Happy flap is a happy surgeon. That's what we all want to be. I think this is just a video of it. I don't know if it's going to play. It's being weird. Okay, while that's loading, I'll give my one tip that is not related to the coupler, but I shared with some of the residents yesterday and students. Sometimes finding your needle, which has been off the field, is a tricky thing, and you're like, where is this needle? And you just spend a lot of time like chasing this. I call it running the bowel. I will, especially yesterday, the sutures were quite long, right? They were much longer than we use in the OR. So my tip and trick is I take my needle driver, I put it down on the background over the suture to create a trap. I grab the tail of the suture, and then I quickly pull. The needle will end up in that triangular space you've created between the background and your needle driver. And that's how I quickly retrieve my needle. All right, that does not want to play. Sorry, video. That's it. Oh, it wasn't 30 minutes. It's okay.
Kyle.
So I love it when I see a valve on my flap side because I'm like, this is great. I'm not going to have a problem with, when I drop my leg down for dangles. If it's right at the actual level of the anastomosis and like it's in the way, I'll go ahead and pull the valve leaflets into my coupler just to get them out of the way. If I have plenty of length, sometimes I do, then I'll just trim it out if it's problematic. If I think the valves have been damaged, they're probably going to be thrombotic, I'll just trim it out. If it's, not going to be a problem, I'll just leave it. And then it's great because I just don't have any reflux into the flap. Right. We do have couplers in the lab for anybody who hasn't played with it yesterday. There's lots of them. And we have the traditional sizing sticks. So
Excellent. So so we used to use the flow coupler all the time with the first generation that had the heavier wire. We did a paper, I think 150 flaps, and showed that there was a very high, it's that 70%, right? So 70% continue to work. Does that mean 30% of your flaps you're taking back? Like if you use it and it stops working, what do you do? So there's obviously I think it's good for like buried flaps, in situations where you just don't have, but you got to be a little bit careful. They've redesigned the wire to make it much more flexible, but it's still a little bit, there's a learning curve. So do you use it, John?
I actually don't. I don't use the flow coupler, but clearly it has a role, especially in a situation where the flap, you can't clinically monitor it. I think if you are going to use it, it'd be nice to have a means of maybe having a clinical means of monitoring. The head and neck surgeons in the audience, you don't want nursing staff poking and prodding inside an oral cavity and every hour, and it makes a lot of sense to use a flow coupler. And if God forbid it now shows an adverse response after hours or days, you can always go back and you do a clinical exam intraorally to confirm or deny whether it's a valid reading.
Excellent. Good. Optics. If you're using a flow coupler routinely, raise your hand. Mayo, huh? Random. Yeah. Yeah. The nurses would call me and say, there's the Vioptics machine is making a signal. And I'd say, adjust the sensitivity. And I was doing that all day. I'm like, why are we even using this? Or my phone would go off. I'd be like, oh, okay, whatever.
So we don't have the flow coupler, and notably, you have to buy a different box if you're going to use the Cook versus the flow. So we have the Cook Doppler. If I'm burying a deep, I'm burying a fibula, there's no other way to monitor, I will throw a Cook on there. It gives me something in addition to my resident, just like, I think the flap's okay. Great. You can't see it. How do you know it's okay? But it is super problematic, right? So I had a case where the signal went away and everyone ran to the bedside, mobilized the OR, and then literally as we were wheeling out of the ICU, the bed hit a little bump and the signal came back. And you're like, God, that's a bad word. Right. Because the Cook, you apply it and then you secure it with a little tiny clip and then you hope it doesn't move because you want it on there, but you don't want it too snug. And like, I don't pull the wire, even though you're supposed to pull the wire, because my attending told me one time the resident aggressively pulled the wire and it avulsed the anastomosis. So I make the resident clip the wire at the skin level. And then every once in a while you get a patient who's like, hey, this wire fell out of my breast. It's okay, because it eventually kind of eroded through. But I have one partner who routinely uses the Cook for every free flap. And I don't know if it's because that's how he trained or he doesn't trust anybody, but also it's problematic. I've had the residents hold the phone up to try to let me hear the signal, and the white noise filter on your iPhone will cancel out. You don't hear anything. It's really weird. And so like I came in thinking like, oh my God, there's zero signal. And then when I got there, I was like, oh no, there's a, it's very subjective, right? It sounds like the ocean roaring. And then it's augmenting, you're listening to see, is it augmenting with respiration and ventilation and things like that, or when you push on the flap and things like that. But that little subtle hum can actually be white noise filtered out when you're on the phone, so you can't tell. We don't have Bioptics, but we have T-Stat, which is a little bit of a similar cutaneous monitor. I use that only routinely on my dark skin patients because it can be so difficult to recognize venous congestion. And like my Fitzpatrick 4.5s, the vein can be totally down and you still have a totally normal arterial Doppler signal. And so if you're not aware of that, you're 2 or 3 days late before you really recognize that that flap is venous thrombosed. So it's not, I love and hate the Cook. You have to have something, I think, if you bury the flap.
Let's not forget, we now have another tool, the duplex ultrasound. So we can hear and we can see. And I think we should all monitor the flap using duplex ultrasound. And we all know that when you initially connected the flap, it sounds a certain way, a little bit more water hammer compared to day 1, day 2, day 3. There's that characteristic change in the tone of the Doppler that lets you know that your flap is doing well. And if your flap doesn't follow that pattern of transition, progression, you start to get worried, even if you get a nice signal. That correlate to different flow velocity. So with duplex ultrasound, you can see it. You can see your anastomosis. You can see whether there's blood flow going through it. There's no ambiguity. And when it comes to the flow velocity, what kind of flow velocity correlates with a healthy flap? And we know that characteristic tone transition over time, but how do they correlate to different flow velocity? That study hasn't been done yet. So definitely encourage everyone to take advantage of that technology, especially now we have wireless portable ultrasound that connects to your phone. So yeah, my recommendation. So this idea was developed at a time when our flap surgery was decreasing. And as I will talk about, we really, with mixed feeling, saw this supermicro limb vessel transfer going away just because we didn't need to resort to it anymore. And now with LVA, OMDA, we, at least I on my service, we don't monitor flaps anymore. And that's a shame. And that's why I'm giving this project out to anyone who is interested, because I can't pursue it anymore. But some study have been done by the Asan group, and they would tell you, I mean, they even used ultrasound to select perforator. Certain velocity, well, if you believe them, over 15 centimeter per second indicates a healthy perforator. Anything lower than that, they don't use it. But my question is 40 centimeter per second better than 20? Over 15 is good, is more better? Again, more studies are needed. And what are the typical acceptable favorable velocity for day 1, for day 2? I mean, these are all very interesting questions.
Sheesh. Thank you, Wei. That's great. Great comment. I mean, we were just at the cusp of the frontier of ultrasound, I think, and that's going to be another application.
Thanks, Sam. I have two thoughts. One, most of us don't leave the operating room until we're comfortable that our flap is healthy. I've found those monitoring devices, a flow coupler in particular, because that's what we have, useful during the inset when it's a strange orientation or you're putting things in tight. An ALT that you're asking to do a little bit more than you think it might be able to do. And if you lose your signal, take out a couple of stitches.
Yeah, we had and it tends to pick up stuff, the flow coupler, that you may not be a problem. So I don't know if any of you in here know Sahil Kapoor. We were doing a flat bilateral deeps with Ahmed, large woman, and we did the flow coupler because we were doing it on every case, and every time we kind of the breast relaxed out laterally, the signal went down, but the flap looked fine. It was just weird. So I think it was like just picking up this subtle change. So I said, Sahil, you need to stay at her bedside and hold her breasts immediately all night. And he was like, sir, what? I was like, yeah. He goes, okay, I'll do it. So then I was walking to the resident room like 2 hours later. I said, where's Sahil? Like, he's upstairs with your patient. I was like, go get him now.
There was Devin Kuhn was a med student in Pittsburgh, and then he went to Hopkins as a resident and then a faculty. They had developed, I think 5 or 6 years ago, I saw this at a meeting, a ultrasound, what is it? Sonovex, is that the one you're talking about? Has that bioabsorbable little platform you set the anastomosis on to ultrasound. Is that what you guys are using? Because I haven't heard anything about that since I saw it at a meeting years ago. It was kind of this biotech startup thing they were working on, but I don't know if you.
For advertisement?
Yeah, they were like, instead of getting a brochure.
Sure, I get it, yeah.
Come to market, is it used? Yeah.
Like,
It like bounced, it gave better ultrasound readings, and then they would, it was bioabsorbable too. Yeah.
I was just gonna make one point about the wire. I had the same thing happen where post update 8, and I took the first generation wire out, and the flap immediately went down, and that was the last time I used that first generation flow coupler. I do like the second generation one. The thing I was going to say though is if you can't get the wire out and you have to cut out the skin, it is MRI compatible. So we've had that come up several times, and I don't know if it was one of our residents here who made like a billion phone calls, but we were able to confirm it is MRI compatible. So if that comes up in the future, you heard it here.
my house had a resident, very case on choice in the patient. accidentally yank the wire out, and you're like, you open and don't tap in. So it comes off and you don't want it to come off, and then it stays on too long and you don't want it to stay long. But it's really all we have for a baried flap, I think, right now, unless our ultrasound technology. My concern for ultrasound is like, am I really going to train this traveling scrub nurse or floor nurse to actually use this properly? Because sometimes we have trouble finding a handheld Doppler to go Doppler flap. I ultimately bought my own handheld Doppler, which I bring to the OR. And so if I can't even get a handheld Doppler, I'm not sure I'm going to train a nurse to do a advanced flap check technique. I just want them to look at the correct flap. I've had nurses report flap has 2-second cap refill, and they check the skin graft donor site.
Oh, God.
Pushed on the telephone, donor site, and the flap is dead. I'm like, oh, that's not the flap. You have to know your system and what's available to you and what will.
Excellent. We should have a whole symposium on why intraoperative Dopplers never work.
How many years of my life
Seriously,
are lost?
like all this stuff. We have like all this amazing ZoomX guy. Come on, work on it. I don't understand it.
I'll never get those years back,
And it's-
waiting for the damn Doppler box. Another one, yeah. Or they sterilize the probe, you're not supposed to sterilize the probe,
Yeah,
or they do it wrong, and yeah.
Let's develop a consensus statement here. John LoGiudice needs no introduction. This is one of my favorite talks. It just really shows some very practical issues and some incredible cases. Makes me glad I'm a microsurgeon here in Madison and Milwaukee, though.
Well, thank you for
Thanks for coming.
for the ridiculous introduction. I'm honored to be here, and obviously there's, this meeting has just blossomed. It's in terms of its growth and scope and those involved. I mean, I'm always impressed. So as everyone who practices knows, this could be like a 10-hour talk. But I'm going to try to hit high points. That being said, I probably have too many slides. I'll speed it up. Sam, just prompt me. We have no conflicts. The reality is, especially for the trainees in the room, is that the microsurgical anastomosis is probably the easy part of microsurgery. There's a lot of variables, and any of these variables, when you're doing a microsurgical case, can derail the entire enterprise, such that you have nothing to show for at the end of the day if you don't pay attention to the details and try to avoid problems in these details. So, to ask the question of success in microsurgery or avoiding problems or complications, you can pose it that way: as, are you doing surgery and it's under the right set of circumstances? Is it the right indications? Do you understand the disease? Do you have the right diagnosis? Is that disease controlled from the perspective of the individuals that you may be working with or collaborating with in the operating room? Is surgery really going to help the patient? If you don't understand a disease, like this patient who I saw in Bucaramanga, Colombia, who had just been bitten by a pit viper, this is not the patient you do limb salvage on, because if you try to salvage this limb, you'll probably kill the patient, as this patient was in progressive shock. If you see this patient who's had a third or fourth recurrence of head and neck cancer, and the ablative surgeon thought, wow, let's try to take another crack at it, chances are you're not going to have a successful outcome with regards to either getting the patient to heal or live longer. You have to also visualize an end result too. We could certainly keep things alive. This patient here who was run over by an individual with a few too many on board, literally, in one of our freshwater lakes, not so far from here. We can keep this limb alive. There's no doubt about that. We can keep it. It can be decorative, but is it really going to heal? Is it really going to work? Are you going to get the patient through the operation? That's the other question. There's some patients that they have difficult problems, and the best solution is a complex solution, but maybe they're not going to make it through the operation like this patient who has pretty bad pulmonary hypertension. And then long term, beyond just the hours you're in the operating room or the days after the surgery, is this patient going to do well? I mean, are they going to be able to be compliant? Do they have a setup where they're going to be able to recover? Would they be better off with simpler operation or simpler set of operations and a far more straightforward recovery, not one measured in years, like this young woman who was run over on Highway 51 in northern Wisconsin by a dump truck at 2 a.m, and we couldn't quite figure out why she was in the middle of Highway 51, but it had something to do with probably her drug abuse. And of course, there's expectation management too. Somebody that came in here and wants to have a normal looking face, are we going to do that for the patient? Certainly we can improve their plight, but so let's just assume these things we've already figured out. And that's usually with in this case, in this room, it's a lot of experience in this room. And so let's talk a little bit about details in the operating room. So let's just assume you pick the right, we'll say in this case, a flap. If we're doing a flap reconstruction, you know how to harvest it, and there aren't any surprises in harvesting it. So the one thing to remember is, when you're harvesting a flap, it has to look perfect at the donor site. If it doesn't look right at the donor site, don't think that miraculously when you move it to the site that you're reconstructing, it's going to look better. And so this is important because there's a certain level of optimism that sometimes folks have. I had a chief resident, they're not in the room, so I'm not throwing him under the bus in front of everybody, but he harvested an anterolateral thigh flap for this gentleman with an infected tib-fib fracture. And I came into the room as we were moving it to the recipient site. And the microsurgery was very straightforward. The recipient vessels were healthy, but gosh, when you released the clamps, it looked really pink, and it wasn't. We waited and waited, and it still looked pretty pink. You scratch it, and it was venous initially, and of course, I asked the question, how did the flap look at the donor site? And there was crickets. So you have to, again, getting back to the theme of details, you have to look at all, step by step, you have to scrutinize each one. And so, when you're sitting here, you're looking at the cap refill, it's instantaneous. Well, the second thing that we did wrong in this case is I didn't just throw the flap in the garbage. I was talked into thinking, well, that flap looked okay, but the reality is the perforator was damaged, and so lo and behold, you harvest the flap with some better anatomy, and now you solve the problem. So I guess there's a lot of lessons. Don't think that your flap at your donor site, if it doesn't look right, it's not going to look any better where you move it. I spend a lot of time talking about recipient vessels because this is really the lifeline when you're doing flap surgery. You can make the same argument if you're replanting anything. Whatever you're going to connect to, those vessels, you really want to make sure that you've scrutinized them. And so you want to choose vessels that are as healthy as possible. Obviously, if you have a vasculopath and every blood vessel in their body is atherosclerosis, you can't be too picky, but try to be as picky as you can. It's always great to have vessels that are in proximity to wherever you're doing the reconstruction, but clearly you have to overlook that. If you need to go somewhere else, you need to go somewhere else. We were talking about size mismatch. Ideally, if you're planning an operation, you want to try to have vessels that, whether you're going to have a size, if you're going to have a size discrepancy, you can go end to side or do the various techniques that have been discussed already. And then, of course, you want to choose vessels that are expendable. There's no reason to potentially compromise somebody's anatomy because you just want to keep your flap alive. I think making sure that you have healthy vessels, that's not negotiable. So, this is not the patient you go digging around in their neck looking for a recipient vessel. You're going to go outside of it. Likewise, this individual had a blast injury, was mismanaged, not adequately debrided, and then infected. You're not going to go look for recipient vessels in here. This goes, it gets back to the concept of the zone of injury. When you do have recipient vessels that you've dissected out, you try to spend a lot of time so that the exposure is as easy as possible. That doesn't mean you compromise the aesthetic result potentially, or likewise, you don't want to compromise critical structures that you'd like preserved, but good exposure is critical, and that allows the microsurgery to be easy, and that's really the whole goal. So wide field, a field that will allow your microscope or whatever you're using to do your microanastomosis to be approached. Microscopes don't look around corners very well, and everything needs to be perfectly dry. Think about it this way: if you have a field that is wet, that is bloody, whether it's the field that the flap is being dissected out of, that's being harvested, or where you're going to be putting the flap, this is where you have to say, maybe you should pump the brakes and make sure that you have strict hemostasis. It will come back and haunt you later, but it will make the microsurgery very, very difficult. And I kind of use the analogy of, we're in football season now, right? If you have a quarterback and they keep on throwing interceptions, it's probably time to sit them down on the bench. So if you can't get through the case, whether it's the flap harvest or the recipient vessel exposure, and you can't keep it dry, then you're going to have to consider changing your approach. I also, especially if I'm not entirely sure, we'll talk about the lower extremity here, about the status of a vessel. I also look for backups. If you're looking to do an anastomosis to deep vessels, if you have superficial vessels nearby or that you encounter, go ahead and make sure you preserve them at the very least, if not, formally expose them and dissect them out. It can help you, especially if you're in a pickle, when it comes time to doing your flap anastomosis. Getting back to this theme of making exposures easy, here's a kind of a weird case of somebody who had an esophagectomy gone awry and didn't have good bowel anastomosis or bowel flap options. So we actually created a total esophagus with a thigh flap, and that's not the point. The point is that you need to have good exposure, especially, this is the distal anastomosis into the stomach, but this is the manubrium that's removed. And, if you really want to go to, in this case, mammary vessels, and you're worried about how the flap's going to sit or how the pedicle's going to lie, the anastomosis done up in the neck was facilitated by removing the manubrium in this case. And, lo and behold, you've got your internal mammaries right in front of you. So this isn't necessarily a case I've ever done before, and fortunately done since. The patient did okay, luckily, but it's all concepts. That's all we're teaching here. If you follow the concepts, you can apply this to the next operation that you're going to invent, okay, or that you're going to describe for the first time. I like, especially in extremities that have been traumatized or have been radiated, or just even if they haven't, I like using a tourniquet. Just remember, if somebody has had a bypass in that extremity, don't use a tourniquet unless you fully heparinize the patient. Their bypass will go down. When I was a junior resident, I had a junior faculty get a earful from our chief of vascular surgery after he ended the case with an ischemic flap, but more importantly, an ischemic leg. Don't cut corners. I think that's the key. When you do your dissection under a tourniquet, you let the tourniquet down, and then you are vigilant about making sure you have great hemostasis. Inspect how the vessels are filling. Look at any areas that might be causing dilatation of veins. Anything that's excessively dilated might speak of something downstream that's problematic. As we talked about, you need to go to distant sites. Do it. The head and neck surgeons in the group all know that the transverse cervical vessels certainly can be your friends. If not, the thoracoacromial trunk. when you're talking about the patient with the frozen neck. If need be, use a vein graft. Arterial venous loops are great. Remember, though, you're going to need a lot of vein graft. And if you're going into an operation that's planned, don't assume that the patient has good veins. You might need to do a vein map to see the diameter of your potential donor vein, especially if you're looking in the legs. You don't want to have a surprise where now you don't have a vein graft when you were assuming you were going to do a large vein graft or an arterial venous loop. I usually like to let loops mature for at least 20 or 30 minutes just to make sure that there's nothing problematic with that conduit before I move the flap. Likewise, you can get creative with arterial grafts too. This is a kind of a weird trauma case that was presented, a while ago at ASRM, where we banked it on a belly and to the deep inferior epigastric vessels because the guy's neck was broken, so we couldn't do the replant the day that he presented. He was in shock at the time. So things to look at with recipient vessels: minimal external scar. Try to look for a vessel that has uniform caliber, soft. Clearly look at the vessel. It might have clot in it, especially veins in a traumatized limb. Venous hypertension I'm going to touch upon, but if you're at all skeptical about a vessel, an artery or vein that you're going to anastomose to, cut the damn thing first. You don't want to harvest a flap, have it sitting there, and then you find out your recipient vessels are no good. Be careful when you're working with other folks about cautery injuries. I mean, I work with a fair number of surgical oncologists. You might assume that the vessels that they were working around were treaded upon lightly, but if there's a lot of damage or injury to it, basically you're going to have to question why you're going to go to those vessels. Veins in particular, if they look distended, make sure there isn't clot in it. Make sure there isn't potentially surgical incisions downstream that might be causing an occlusion. And then there's this concept of venous hypertension, which we don't talk a lot about in microsurgery or limb salvage, but the vascular surgeons certainly can talk extensively about it because it usually presents as blood clots. And this is usually in the patient that has a lot of centripetal obesity. This is a almost 400-pound gentleman that somebody had the bad idea of doing an ankle replacement on, which, shame on that orthopod. But of course, he had complications healing, and so we had to do a flap. And this is a real issue if you're trying to do a flap on a patient with venous hypertension. This is the saphenous vein, and the vena comitantes, in this case, of the posterior tibial system, they were under just as much pressure. That's a terrible pressure gradient. You can have great inflow, but that outflow is going to be a difficult. That's difficult physiology to keep a flap alive, and so you have to scrutinize vessels. This is particularly the case in the lower extremity. If you are working around vascular bypasses, of macrovascular bypasses, I like to stay upstream of them because if that bypass goes down, I don't want the flap to die. And so clearly we've learned that you don't do microvascular surgery to PTFE grafts, but in this case, this is, these are anastomoses above the common femoral vessels that were exposed for this medial thigh sarcoma. As you can see here, you don't want to find out the hard way that you went downstream because it was easier, you had a better exposure, and then all of a sudden, if that PTFE graft has a problem, especially the venous graft, which inevitably they all clot, now you have a flap that's compromised. I like to scrutinize vessels. I don't systemically heparinize people unless I'm, for instance, clamping to their femoral artery and their whole limb is ischemic. But I flush flaps, as we've learned in the 80s from replantation. I flush it with heparinized lactated ringers. I want to make sure I see good flow. It easily flushes with regards to how the syringe feels as you're flushing a vein. These are all things that are important. when it pertains to the recipient vessels. I also want to scrutinize, obviously, if you are going to a limb, you want to make sure if you are going end to end, that you can do that safely without compromising flow downstream to the limb. Jacqueline was emphasizing, the anastomosis is one thing, but the lie of the pedicle is really important. So you can inset the flap, but if you have too much pedicle length, you might have to shorten the pedicle, or you might have to create room in the space that you're insetting to let the pedicle have a nice, easy lie. Same concepts that we've talked about before. Surgical field should be dry, good visualization. You should be comfortable. There's different philosophies and schools of thought about how much to clean a vessel. You don't want to strip the adventitia off a vessel. That makes it vulnerable to clot. But on the other hand, you don't want debris in the field. You don't want to find out that you're struggling to do the anastomosis and you've got fat and other debris that's going into the lumen of the anastomosis. I always mark the pedicle before you do a transfer, just like if you're doing a vein graft, you mark it to ensure that there aren't any twists or kinks in it. It just saves time. You don't want to find out that you have a 180-degree or 360-degree twist in something. We've talked about the coupler. I don't want to belabor that, but these are good times to inspect after each step. I know I wish I had this videotaped, but I had a chief resident that was doing a flap in another room, and they were literally, I walked in and they were high-fiving each other. The two residents, the two senior residents, there might have been a fellow in the room too. And I walked in and I looked at the flap and it was clearly not flowing. And so a lot of people think that this is the end of the football game. Time is up and you've won. This is really only the end of the third quarter, So you've done the anastomosis. Now you really want to inspect things. Inspect the entire pedicle, inspect how the flap looks, etc. You want to make sure that as you're insetting the flap, you're scrutinizing every step. And that goes back to the question of flow couplers. It's nice because it will tell you immediately if something is going wrong while you're insetting the flap in the operating room. Make sure that there's not too much tension. Sometimes you have to do myotomies and things, assuming that you can. It's something you can cut without an impact on the patient's overall function. Make sure the lie is really good. Sometimes I use various technologies, i.e. gel foam. These are things that sometimes will keep especially if you're operating vertically or the pedicle is vertical, it doesn't twist or kink as you're trying to inset. Pay attention to everything, obviously clinically, whatever technologies you decide to use. You have to really look at things closely because, as I mentioned in that earlier case, you don't want to find out you've been looking at a flap that essentially isn't going to. You don't want to leave the operating room with a flap that is going to end up coming back, and we know that this isn't optimal here. You occasionally will have patients that will do things post-operatively. You don't want them to do like sleep on their flap 3 weeks later, and this guy's about 290 pounds, and this is on his hip, so sometimes you can't avoid it, but looking at everything, what happens, what are the things that I just wanted to mention? First of all, getting back to, the disease, or in this case, this was a technical matter. This patient had a bad infection from a huge tumor, was radiated. We did a oral cavity reconstruction or lip reconstruction, and on day 3 blew out. And this is a scary thing for everybody. If you've ever had an arterial blowout, whether it's treating vascular surgery patients or doing microvascular surgery, this is a real issue. And I think to get back to complications, how do you avoid this? Make sure the disease you're treating is treated adequately, especially if it's an infection. You want to do microsurgery in an infected field, be really cautious. Or more importantly, an infected and irradiated field, like this gentleman who had a large sarcoma resected at an outside institution. They didn't do a flap to close the leg. The leg was open for months, and then we did a flap, and lo and behold, on post-op day 3, his SFA ruptured and he coded on the floor. Luckily, we went to recipient vessels outside of where the radiation and the wound was located. So despite this tourniquet on his thigh, which saved his life, luckily the vascular surgery fellow happened to be on the floor when this happened. That's a miracle. But that tourniquet, despite it compressing everything in the thigh, the flaps made it. We ligated the SFA, and he went back and had an extra anatomic bypass, a week later. I don't want to belabor this, but you can't have patients sleep on their flap, like this individual here. If a lot of what I do is, this is another patient. This patient probably slept on her flap. So we ask people to sleep in a recliner, an easy chair, get a foam wedge pillow post-operatively, so that they're not doing anything crazy. Generally speaking, this is not a salvageable scenario. Obviously, this flap's dead as a doornail by the time the patient made it back to the hospital. But delayed flap thromboses statistically have a poor outcome. For extremities, I do all sorts of kind of crazy things with X fixes if need be. It's critical as much as it's a pain in the butt for the patient. If we're going to go through the trouble of saving their leg, then or their arm or whatever it may be, they're going to have to suck it up and deal with the X fix. Sometimes you don't really have a choice if you're doing a flap, especially to a lower back or buttock, which is really a pain, literally in a butt. This guy had a sarcoma in his butt that was the size of a basketball. And, now what do? You're going to have him sit on it? Well, it's not going to be a good outcome. So these are all things that you have to coach people through before you do the operation so that you're not backpedaling when they say, I can't believe you're making me do this. Thank you.
Amazing as usual. So I just have one comment. So seeing a flap prior to division pink or any other color than what always makes me nervous. We always say, well, this must be a superficial dominant. Like if you're saying stuff like that, chances are it's not going to go well.
I think you should be, at the end of the day, there's, if microsurgery was easy, there'd be a lot more people doing it. Okay. And so it's not easy. And as much as we'd love to algorithm everything, I mean, it's as learners, it's much easier to have an algorithm for everything. But if you're looking at a flap and it's, maybe the patient's has Fitzpatrick 1 skin, and maybe everything, including the staples that were put in them while they were being draped, everything turns pink. You can say that might be how they're reacting. But if the performance of the flap doesn't look right, don't waste your time moving it. It doesn't make any sense. Rarely do you, quote, get away with it. And I use that example. It's certainly not the only time that's happened, but generally I emphasize, scrutinize what you're doing. Even when you're raising the flap, we've certainly had people raise a flap and damage a perforator, and maybe there's 2 more next to it, but it may not do the trick. So there's no reason to waste the steps of harvesting and then doing an anastomosis only to find out that your flap was garbage to begin with.
Great. The other thing I wanted to comment on and maybe just have a discussion about, because this is I think a challenge in being a microsurgeon in an academic setting like this, is typically when we're doing a difficult free flap or a routine free flap, the attending is the one who does the recipient vessels. At least that's how it was when I trained here in Melbourne. And then suddenly you get into the OR when you're an attending, you're like, oh, I guess my job's now to do the recipient vessels, and you don't really know how. So how do you manage that with residents, and how does the faculty in here manage it with residents?
So I'm going to have folks that are going to call me out on this, but I'll be the first to admit, I look at it this way. In most circumstances, well, let's just say breast reconstruction aside, let's just say you need 2 flaps.
Right.
It's a bilateral or it's a unilateral, it needs 2 flaps. I look at it as the recipient vessels. If something goes wrong with the recipient vessels, and of course it depends on the location. If this is up in somebody's iliacs, or if it's in a neck that's a mess, there's a lot of collateral damage that can be done, and you still have nothing to show for if you don't have a healthy recipient vessel. So I do have the tendency to dig out the recipient vessels, and that I think if you have the skill set to dissect out a flap, you clearly have the skill set to dissect out the recipient vessels. My hope is that whatever you're doing technique wise, it's gonna certainly pay dividends when you have to do the other part of the surgery. But I will find that when you have a trainee do it, they have a tendency to under dissect. They have a tendency to potentially have not great hemostasis. They aren't really thinking about, well, eventually I got to bring a microscope in here. I mean, I can't be looking upside down, to do the anastomosis, or there's an excessive use of clips, which I probably should show that picture too. There's clips everywhere. I mean, you can't do an anastomosis anywhere. There's metal everywhere. It's like a Christmas tree with tinsel on it. You can't do that. And then there's the things that you can't see. Is there a traction injury? Is there cautery? You cut the vein. You're like, why is there a clot in this vein? This is nobody's ever been here. But it's because somebody was pulling and tugging and grabbing, or there's heat, and so you don't want to find that out. And then now you're kind of derailing the whole. You're not here. The people in this room are not. Let's do a 14-hour free flap. I mean, it's just not good for longevity, you or the program. So you want to be efficient, and these are all part of. If you do the steps properly, as long as you're doing them properly, your chances are your efficiency is going to be really, really good, and you're not going to have complications that are measured as how many flaps have you killed lately.
Excellent.
I think up to 2 or 3 years ago, we did not have specific emphasis on the field of recipient vessels in microsurgery, but now there's a published book. And I recommend every one of you who is starting to get the book. It includes cadaveric dissection videos and some recipient vessels that you might be unfamiliar with if you didn't practice them. So it's essential. Technical pearl point, if you do lower extremity reconstruction, I think start with the recipient to see what you have, and then the key would be like a soft pliable vein. And since a vein normally comes paired, you can cut it and see how the flow to the vein is. You can even, with a heparinized saline, you can flush it and see if there's no resistance to it. So those are the clinical signs of a healthy recipient vein. And that's the key. That's what's going to make it or kill your flap.
I agree this is something that it can be easily overlooked and forgotten. So I'm actually very deliberate about teaching recipient vessel preparation with my residents. I think this is part of the game plan going in before the case. Who's your team and who's planning to do what? So a resident should be assigned, and then you adjust. If you have a junior resident who's dissecting vessels for the first time, maybe you're spending more time as a faculty member showing it to them. Versus I do have chiefs who realize they're about to graduate and they're like, I think I'd actually like to do the chest vessels. And I'm always like, oh, they are now consciously of their incompetence, which is great. Also, deliberate in which vessels you're doing, right? Right chest versus left chest. Radiated vessels are not a great learner. So I will not, on a very junior trainee, allow them to start with a radiated chest. I will always do that. But it's often bilateral. So I'll show them the radiated side and then I'll say, okay, now why don't you try the non-radiated side? If I have a very senior resident, then, maybe I'll just let them have a whack at it. But I think you just have to be very intentional and knowing what level of training you have, what is the recipient vessel. Absolutely agree. I do a lot of lower extremity. Sometimes I tell them, you do not make an incision on that flap until you have recipient vessels out, because otherwise if you don't have recipient vessels, there's no flap to be done. And so I'll have the senior resident and the junior resident work on the recipient vessels. If you have the privilege of 2 attendings, this is a perfect situation to have one focused on the recipient vessels and teaching that, and then the other one working with the other resident to lift the flap. And so we do 2 team deeps, and one of us is the ghost surgeon and one of us is the primary. So the primary surgeon we will decide, hey, are you going to do flap or chest today? And then which resident are you going to pair off with and try to make that assignment. So the resident also knows, today I'm going to be doing recipient vessels. I better brush up on that anatomy. My independent residents sometimes are more familiar from doing vascular surgery with, exposing the posterior tib and perineal. And so I think if you're intentional as an educator, they will see the value in that and realize, especially a leg that's been open for, 3 weeks, those vessels are hard. You're chipping through concrete. And I've had residents I think I found the artery, but I can't find the vein. I'm like, no, that's the vein. It's just really fibrotic. And so you underestimate, sometimes that is the hardest part of the case.
Absolutely. And then one other final thing is just if you're in a situation or an area of the body where you're uncomfortable or you don't totally know the anatomy, we don't do a ton of head and neck reconstruction. ENT colleagues do. They're incredibly collegial. So next week or a week, call for 2 weeks from now, I'm going to doing a clavicle reconstruction with a prefib. And I'm going to get Aaron, you don't know this yet, Aaron Whelan, Wednesday, the 6th of November.
Recognizing the source.
7:30, room 5. And to help with just find vessels. They do this every day, several times a day. Way. And if he's going to go to the mammaries, he may call us, right? So call for help if you need it. And this isn't about ego. It's about getting the
Not only for things like preoperative workup, clearly not even things that whole problem. We wrote a paper on never-induced onset of E, and I think I would have written a paper that just said, hey, these CT hands does not reach, and patients can die.
Okay, thank you, John. Great talk. So another man who needs no introduction, Wei Chen, Cleveland Clinic. You've been coming to this course for a long time. I know last couple of years you haven't been here, but I think you started almost with us from day one. So thank you for your commitment and your contributions to Supermicrosurgery and what you're doing for the field and individuals with debilitating lymphedema. So we're really excited to hear this. And then Keynote's talk a little bit later where he'll talk about the other stuff. So
Thank you. So this is one of my favorite meetings of the year, and it's a shame that I had to miss the last 2, and I'm really happy that this year I could make it. And yeah, thanks a lot, Sam and Wei Fang. Great meeting. And I'm very happy to see this meeting, this course growing every year and where people can get together and learn from each other. And by the way, that last talk was phenomenal. John's talk. I heard so much wisdom in that talk, and I know how much hard work that goes into building that much wisdom because every time you made a painful mistake, you learn. And to be that wise, you can see how much pain that's gone into building that up. Anyway, so my talk is to, in my mind, supermicrosurgery is really the logical next step, next evolution of microsurgery. So for those of you who are just thrive on challenges, this would be for you. And it's a lot of fun. We all know that gratification correlates with the degree how challenging the task is. The more challenging, the more thrill, the more gratification you get. And another reason is I hope to encourage, if you're not already performing supermicrosurgery, lymphatic supermicrosurgery, that I can get you excited and maybe helping this patient population because they're extremely underserved. And so I'm calling it lymphatic supermicrosurgery, but there should be a distinction should be made between supermicrosurgery and lymphatic surgery. It's just that currently, so supermicrosurgery is supermicrosurgery, but currently supermicrosurgery is being used, applied extensively in the treatment of lymphedema. So people are thinking that one is the other. Actually, there are two distinct entities. All right, so I always gave this quote, and I always thought Confucius said it. Actually, Confucius didn't say it. It's from this Greek guy. The only constant is in life is change, and that really should apply to modern medicine. That really should apply to microsurgery, to all that we do. I always remind myself that state of the art today, cutting edge today, will become obsolete tomorrow. So at any lecture, you will never hear me saying, this is what I've been doing for the past 20 years. And I think that's a sign that we haven't progressed. So we expect our phone, our cars, everything to have a new model coming out every year. And I think so should our surgical technique. Not necessarily every year. We don't need to have innovation advancements every year, but we should always strive to be better and not be complacent with where we are today. So just like human evolution, we get better and better. We went from crawling to standing to using tools to now we have a small handheld computer in our hand, going from really primitive iPhone 1, even though back then it was cutting edge. I immediately bought one when iPhone 1 came out, and it was, everybody was envious, but tried carrying an iPhone 1 today. And same thing with lymph node transfer. When I first started, that was developed in 1990. And then we developed lymph vessel transfer, completely switched over. And then now I don't do either lymph node transfer or lymph vessel transfer anymore. Now for fluid lymphedema disease, we perform LVA and LMVA. So the years represent the year it was initially described, and you see LVA, that's our LVA technique that evolved up until 2018, and I'm a little bit embarrassed to say that since 2018, there hasn't been new innovation when it comes to LVA technique. Our LVA technique today is fairly similar to 2018, and it either means that we have really beat this horse to death, and there's nothing new to be. Anyway, we're still looking. LMVA is definitely our new love. It's working great, and we're still refining the technique. All right, so a little bit about how my lymphedema surgery practice had evolved. I started out because no one was helping this patient population, and I was collecting cases for plastic surgery board. So everybody said, don't do crazy cases during your board case collection. So I told them, come back in a few months, I can help you. But eventually I couldn't resist because I knew I could help them. So I did my first case. After that, the floodgate opened and I started doing lymphatic surgery. And of course, my lymph node transfer case got picked for the board. As it turned out, it was great. So don't believe in people telling you conventional wisdom. Sometimes they are not right. So I started out performing lymph node transfer. And pretty soon I brought LVA into the picture because when I talked to the patient, I always said there's lymph node transfer, there's LVA. I do lymph node transfer, and lymph node transfer is better. And patient said, how do you know? Well, I really didn't know. That's what I was taught. And I think we should always ask ourselves the question, why? Why do we do what we do? What's the rationale behind? If your answer is, you don't know, this is how I was taught, then you've just identified a knowledge gap. And that means opportunity for investigation, research. So the best way to find out which procedure is better is that I become an expert in it. So with that in mind, I learned LVA from Koshima. I began offering LVA, and later on, I also introduced lymphatic liposuction, developed our own technique called Matisse, and with that, we retired the classical SAPL technique developed by Professor Håkan Brorson. And 2014, we developed a hybrid sequence, and this is 180-degree opposite to the conventional wisdom of recon first, debulking later. We found out that it actually didn't make any sense to recon first, debulk later. Debulk first, recon later is much better, and I will explain to you why later on. Then I developed Koshima developed the foot-based, FDMA-based lymph vessel transfer. We performed that procedure. We found that it worked, but there's some drawbacks to it. So we came up with the skip base and TDAP base, essentially ultra-thin skip flap and TDAP flap, which carry a lot of lymph vessels. And that was our versions of lymph vessel transfer. And that works great. Those are two little supermicro free flaps. So supermicro isn't just LVA. You can do supermicro free flaps. Everything that John said about micro applies to supermicro free flap. About bloodless field, about preparing everything meticulously, about, so much wisdom there. Maybe I should get that talk from you, John. So 2016, we stopped doing lymph node transfer. We completely switched over to lymph vessel transfer because it basically did everything that lymph node transfer did. And that's when we finally concluded that what's working in the lymph node transfer flap was never lymph nodes in the first place. Lymph nodes were just spectators. They were just for the ride. It was actually the lymph vessels that treat lymphedema. 2016 was a turning point. That was when I came across Michael Niedergaard's and Antoine Louveau's studies about brain also having lymphatics that opened up a possibility for us to potentially treat brain lymphedema, better known as Alzheimer's and Parkinson's and various other diseases, ALS and so on and so forth. And then we developed the so-called distally based delayed LVA or DDLVA to treat subclinical lymphedema or to prevent lymphedema in patients who already sustained lymphatic injury but remain asymptomatic. 2018, freestyle LVA, so no more talk about what's the best anastomosis. Side to end is always the best, I'll always go with that, or octopus or whatever. Beggars can be chooser, you gotta do what the situation calls for. 2012, 22, we stopped doing VOVT. Well, this is getting long. Anyway, this is just to show that we kept on evolving. And so hopefully next year when I come, there will be something new and something different that I won't be repeating this talk. So up until now, I've been going at it for 15 years, over 2,500 cases with over 1,200 LVA cases, not connections. All right, this was my protocol back in 2011. I was doing, as I said, pretty much all lymph node transfer, and I was ignoring stage 0 disease. We weren't doing any prevention or proactive treatment to asymptomatic lymphatic injury. For example, breast cancer patient following reconstruction, lymph node dissection radiation, they've already sustained lymphatic injury. They're just not symptomatic yet. So if you want to be strict, as a lymphologist, I can tell you those patients already have lymphedema. They have stage 0 lymphedema. So to say that they don't have lymphedema, that's actually inaccurate. Wasn't treating any of those stage 0 disease patient, and I was a amateur LVA surgeon, and liposuction was frowned upon by us microsurgeons, so tried to not do it as much as I could. So I was ignoring most of the solid disease cases, and I was unfortunately had to do a good amount of radical excision. This is my protocol now. It's dramatically different. Lymph node transfer is gone. Replaced it with lymph vessel transfer, but the indication is extremely limited to the point that we think that it's probably gone. But I still kept it on my protocol. Now we have effective treatment for stage 0 disease, and I think all patients who sustain significant lymphatic injury, you can help them. You can abort the whole process. And we're doing a lot of liposuction, and this surgery is incredibly boring and yet incredibly powerful. It works so well. Patients are loving it. Patients are so happy, and that's what's keeping me going. But in terms of the joy of performing the procedure, it's not fun. So now we're capable of treating all fluid disease, predominant disease of lymphedema with LVA and LMBA. So you can see the indication for lymph vessel transfer, VOBT, is very, very tiny. And as I said, lymph node transfer is already obsolete, and the lymph node transfer 2.0 or lymph vessel transfer is on its way out. And fortunately, we're now rarely need to do Charles procedure, or the lymphatic supermicrosurgery fellow who's graduating next week. I don't think she's seen one Charles procedure, and that's a good thing. And as I mentioned, we call this the hybrid sequence, debulking first, and then recon later. This is a very powerful way to do LVA. Your LVA will become so much more effective than if you were just to start out with LVA. I call that LVA on steroid. Okay, so there are lots of new things. Since I haven't been back at this meeting for 2 years, we have a lot of new things that we can report to you, but I don't have enough time. So I'm just gonna share what I consider the most interesting. Number one, lymphedema is curable. Now I can stand here and definitively tell you lymphedema is curable. I saw my first case of cure in 2012. I tried to publish it. Everybody was poo-pooing it and couldn't get it out. And I think this paper was finally out 2 years ago, 3 years ago. So the field had to develop enough to finally be receptive to the idea that lymphedema can be cured. So, but we shouldn't be patting ourselves on our back, because it's only a small percentage of patients, only 5 to 7%. So we need to look into it. Why are we curing so few? It's curable, and why we're not curing most of them. And then really no reason to go to lymph node transfer. So I think lymph node transfer works, but it has a lot of downsides. And if you're interested in what are the downsides, if we have time, we can get into it. But I think it served its historic purpose. But at the same time, I think we as surgeons, we need to be practical. If that's the technique that works well in your hand and you can't get any other technique to work, then do it. I mean, nothing wrong with doing a technique that works in your hand, but just know that if you're interested in more sophisticated technique with less morbidities and still delivering similar outcomes, there are those techniques that are available. Hybrid sequence I talked about, and I will talk a little bit more about it. And also a very important concept is that primary lymphedema is systemic. It's never regional. Never seen a single case of primary lymphedema affecting only one part of the body. So interestingly, 70% of the primary lymphedema patient will present to you with left-like swelling. So in your chart, they probably were sent to you saying primary lymphedema of the left leg. Well, rest assured that it's also in her right leg. It's also in her face, her torso, her arms. Just do lymphatic imaging, you will find that the defect is systemic throughout the body, It's never regional. Fortunately, when you start to treat, everything improves. Even if you've only performed surgery in the left leg, everything will improve. And you will also be able to demonstrate that on lymphatic imaging using ICG lymphography. So those are the new concepts or the newer concepts. And I will talk a little bit about the new techniques, the LMVA, which you saw a demonstration yesterday. We did it blind without any of the imaging guidance. Most commonly, we perform our LMVA with meticulous preoperative ultrasound evaluation, selection of the lymph node, and we tag the lymph node, the best lymph node with Savvy Scout. And I call this the LVA, if you're a gamer, God mode. It's so powerful. It's like, I don't know how many, 20 LVAs combined. Another new technique is LNVA, even though originally developed on the inguinal lymph nodes, you can extend it throughout the body. Anywhere you have lymph node, you can perform LNVA. So far, we've successfully extended to other parts of the body, knee, face, arm. We're looking into central lymphatics, the pelvics, in the chest. And so that's the next frontier, the central lymphedema and rebuilding the central lymphatic disorders. And what's next? Alzheimer's and Parkinson's, obviously now it's not just us, everybody around the world. So many lymphatic surgeons around the world are now all working on this. You're going to see, I expect multiple case reports coming out within the next 2 years from around the world. And chances are others will beat us to the human trial just because we're so regulated, heavily regulated. But we are still tackling this problem with indirectly with so many projects that are quite exciting that I will talk about a little bit. Cognitive deficits and primary lymphedema. By the way, primary lymphedema is associated with cognition impairment. And this is an indirect evidence that brain has lymphatics, and brain lymphatics are also impaired in primary lymphedema because, as I just said, primary lymphedema is systemic. And so that's not the question. The question is now, can we treat them? Can we improve? You have a primary lymphedema patient who said, my memory is so bad, I can't read because when I flip to the next page, I already forgot what I have read the last page. Can you treat that with lymphatic supermicrosurgery? We think very likely we can. And all right, robot. Obviously, everybody's talking about robot. We are fortunate that we've just acquired this Italian robot that I think among the competitors, I think it's the best at the time for the time being. Our trial will start in December. So yeah, it's another exciting project. Okay, the new concept. It says that lymphedema is curable. Our cure rate has been about 5% up and down. As you can see here, I look back myself in 2021 to 23, every year ranging from 4.7 to 7% of cure rate. I don't have audio here, but if there's audio, you hear this patient raving about our surgery, how she is completely cured. So what does it mean cure? Cure means no symptoms and no need for further treatment. And my prior study, which never was published because no one was willing to accept it, I broke it down. I was more anal at the time. I was younger. I broke it down to lymphographic cure, which means no evidence of disease on lymphatic imaging. And then clinical cure, which is a lower level of cure, no symptoms, no need for ongoing treatment, but you can still catch disease on lymphatic imaging. So cure is definitely a clinical reality, but we are only curing very few patients. I do see a pattern. They're much more commonly achieved in acquired arm lymphedema. So this means that acquired arm lymphedema or breast cancer related acquired arm lymphedema is the lowest hanging fruit. If you're interested in helping this patient population, that would be the patient population to start with because they're the most responsive to treatment, they're the easiest to treat, and they're the ones who get the best result. So I always encourage, by the way, these patients are incredibly frustrated, helpless, sad when they come to you. You tell them, hey, this is actually the best, yeah, I'm sorry you got lymphedema, but this is the best lymphedema to get if you have to get it. You can, give them a silver lining. As I've said, lymph node lymph vessel transfer are not necessary anymore because LVA treats all fluid disease. Here's a demonstration of the octopus, our now well-known octopus technique. We're not doing octopus all the time. Octopus is just one anastomotic technique. So you do it when the situation calls for it. If it doesn't, then you don't do it. So LVA is great because it doesn't hurt any other parts of the body. It's nearly painless. Patient will wake up and say, "Did you do anything? I don't feel anything." And it's, I guess there should be a quote, easy. So once you get the hang of it, it's easy and it's very fast and has a, once you get the hang of it, you can achieve high consistent success and patient loves it. The only downside is that it's very repetitive. So we're working on doing, over the years, I've been doing less and less incision, less and less connections, just because it's really boring and very repetitive. But again, just like the liposuction, it works great, patient loves it. But in terms of enjoyment of performing the surgery, it's not that fun anymore. Now you can see everything is draining nicely. Okay, liposuction, as I said, works incredibly well, but very boring procedure. Interestingly, everybody assumes, so that this is an example why medicine and science are not common sense. So don't common sense medicine and science. When you do liposuction, you're stripping out tissues, and you would assume that you strip out lymphatic tissue. If you're stripping out lymphatic tissue, you should be damaging, further worsening lymphatic function. That's what common sense would suggest, but that's not the case. Although it didn't stop surgeons from already developing technique, the so-called lymph-preserving liposuction. But the interesting thing is people never bother to check, did it really damage the lymphatics? Is the lymphatic function really worse after liposuction? Well, if you check, you will find out not only that, here you can see in this picture, before liposuction and after liposuction, how the lymphatic function has improved. You can see so much dermal blood flow prior to liposuction, which has dramatically reduced following liposuction. Again, this is a study that we were trying to publish for many years. Finally, it got published last year. That liposuction actually does not worsen lymphatic function. It paradoxically improves the lymphatic function. All right, so I think everybody agrees that the better the quality of the lymph vessels, the better your LVA will work. So this is the reason why we advocate you should do liposuction first and LVA later, because now you get to work on qualitatively superior lymph channels. So do LVA after liposuction, not the other way around. So here's a demonstration of the hybrid sequence. You can see this is before liposuction, before Matisse liposuction. This patient was already having numerous infection, wearing a really heavy garment, flat knit class 4 garment. She was on continuous suppressive antibiotic because when you stop the antibiotic, she developed an infection. This is after liposuction. Her arm already looked great. We removed 2,700 cc from her arm. We gave her a brachioplasty, arm lift simultaneously, so she really loved how her lymphedema arm looked. Actually, many of our patients, and some of them requested cosmetic liposuction and brachioplasty on the healthy arm so that their healthy arm can look as good as their lymphedema arm. After liposuction already worked great. Infection stopped. She got off suppressive antibiotic, and she was able to wean down to a much, much lighter garment, circular knit class 3. And I think this was 2 years out or 3 years out. We went on to perform LVA, and we were able to find these really juicy ectatic lymph vessels that you would not expect to see in a patient with Campisi 3 or 4 disease. And so that's what was done. This is a triple LVA, I think double end-to-side and one end-to-end. So again, about the anastomosis, I think people debate about end-to-end, end-to-side, side-to-end, lambda, pi, octopus, which one is the best. I think that's really unnecessary because, like in this case, I only have one vein, I have 3 lymph vessels. and they're all size match. So obviously, double end to side and one end to end would be the way to go. All right, so our volume, switch gear to primary lymphedema. So we see a lot of primary lymphedema. So our annual clinic volume is about 1,900 to 2,000, and about 60 to 70% of these patients have primary lymphedema. I'm not sure why we get so many primary. Maybe that's because many centers don't treat primary and they only treat secondary. Maybe that's the reason. But thanks to that, we have a healthy amount of experience, data on primary lymphedema patient. And that's how I could tell you, because we performed ICG study on all of them. That's how we can tell you 100% of these patients have systemic disease. And this has clinical implication. It means that they have problems throughout their body. It means that their lymphedema time bomb, even though right now only left leg is swollen, 10 years down the road, maybe right leg will be swollen. Further out, maybe face will be swollen. So this has meaning for oncologists. Yes, sometimes they won't be doing anything different, but sometimes they can. For example, lumpectomy, lymph node dissection, radiation versus mastectomy, no need for dissection. In that case, if you have a primary patient, go with the limb preserving approach. So just because you can so easily trigger their lymphedema. If you're seeing a patient who's about to get pregnant, let her know chances are after pregnancy, she will develop lymphedema in other parts of the body, because pregnancy is another stressful event for our body's lymphatic system. And also there's an age-related loss of lymphatic function. So you will see primary lymphedema patient becoming symptomatic in their 60s, 70s, or even 80s. Well, some of us call that senile lymphedema. It's actually age-related loss of lymphatic function. So the entire body is at risk. And as I said, fortunately, when we start to treat a part of the body, the entire body improves. Okay, now moving on to the new technique. The LMVAs I've been talking about. So here in this picture, you can see the epitrochlear lymph node, which is just above the epicondyle. And you can see how that lymph node, you probably heard of the term lymphosome. Lymphosome, what is a lymphosome? Lymphosome is the territory and all of the lymph vessels that a lymph node drains. That's a lymphosome. And what I have highlighted there is the lymphosome of the epitrochlear lymph node. So that lymph node drains all of these lymph vessels. So when you bypass an LVA, you bypass a single lymph channel. But when you bypass a lymph node, you bypass this entire lymphosome. That's why conceptually, assuming this lymph node is still working, it's so powerful. Here you can see the sentinel lymph node in the armpit, again, draining so many lymph channels, hundreds of lymph channels. And if you're counting pre-collectors and capillaries, then thousands of lymph channels. Sonia had showed you this yesterday, the original concept, the original technique, which probably caused too much trauma to the point of killing the lymph node. And that may be why it didn't work so well. This is the modern version, originally by John Pack, 2021. He gets credit for coming up with the idea of poking a hole in the nodal capsule and then anastomose the vein to it. So what we brought to the table is qualitative selection of the lymph node, finding the best lymph node with ultrasound, and then tagging it with Savvy Scout. So this is so important. If you don't have localization, precise localization, you'll be spending a lot of time just searching for that lymph node and searching for the vein. So use modern technology, get everything, get as much information as you can before you go into the operating room. And as shown here, we've been able to consistently achieve skin to node time of, well, it's not less than 20, I would say 20 minutes plus minus. Yesterday, you saw the demonstration on pre-tragal lymph node, and we selected that because that's the only one that we can relatively easily do without localization imaging, because this one is so anatomically consistent. Growing, not really. Popliteal, not really. Epitrochlear, not really. And I just said LVA is easy. LMVA is easier. As you have seen yesterday, it's really, really easy. And fortunately, well, easy is boring, but fortunately, the result is great. So, yeah, so in our experience, LMDA is more powerful than LVA. So if this continues, we have ongoing studies on the technique. If this continues, I think it will start to cannibalize on our LVA, just like what we've seen with lymph node transfer and lymph vessel transfer. All right. So performing LMVA, extending LMVA technique to outside the groin to treat lymphedema everywhere. And this, we go to our cadaver study. As I said, LMVA started out for the inguinal lymph node. We've been extending it to the face, to elbow, and to the leg behind the knee. Here is, I just throw this in from our case on Wednesday, because it demonstrated a technical trick to help your LVA work better. And so many lymphatic surgeons, since we are all microsurgeons, and microsurgeons, we were indoctrinated to think no pressure on the anastomosis. Do a lot of pressure, put pressure on your anastomosis. In fact, put pressure everywhere, and not just pressure, strong pressure. This shows you, now this is a bad looking LVA. You can see the backflow, blood in the lymph channel, but look as I start to push on it. Okay, you can see blood is now dripping, flowing back into, okay, I gave it a push, gave it another push. Every time I push, we are selectively augmenting the lymphatic pressure. So this is actually a very strong lymph vessel, but this vein was even stronger. So if you don't compress, this LVA was shut down. This LVA won't work at all. So this is such an important trick. And so we always immediately compress, and we compress strongly. So immediate strong compression makes your LVA work better. It will augment those, make the ones that are already favorable even stronger, and it will convert the ones with backflow, which would have otherwise shut down, to favorable LVA. So we've published this quite a while back, but it seems like not too many people have read it. So here you can see, here's our study methodology. We complete the LVA, and in this case, octopus LVA. You can see all three lymph channels have backflow. And when we apply compression, all three converted to washout. Not only that they converted to washout, you can look at them, they all have become fatter. It's indicating to you there's a lymphatic hypertension, which is actually a good thing here. We collaborated with a professor in physics who helped me draw this picture, but I won't bore you with it. And he was amazed how I didn't understand this high school physics. And he said, it's so obvious. Why are you even asking? But anyway, if you're interested, you can look at our paper, the physics behind it. It has to do with an open, free-flowing system, which is the venous system, which you establish a communication with a partially obstructed system, and when you apply external compression to both systems simultaneously. All right, so as I said, Alzheimer's and Parkinson's diseases have been found to be lymphedema of the brain. Won't bore you with the lymphatics and meningeal lymphatics. You can just look at actually, I'll be talking more about it later on today, so we'll leave it for that talk. So low-hanging fruit, this is a trial that we're about to start in December using this Italian robot and this exoscope. So we'll be doing converting our surgery to robotic, and we of course will have a trial comparing the robotic and human. Actually, I already know the result, but all right. So my hypotheses for the robotic trial, obviously everybody's asking, will the robot be better than human? I think unlikely, highly unlikely, at least not for the standard supermicro from 0.1 to 0.8 millimeter in the hands of well-trained supermicrosurgeons. I think it'll be tough to beat. And so what good is the robot then? These are the indications, benefits that I can think of for the robot. Number one, puts supermicrosurgery in the hands of non-supermicrosurgeon. Well, it takes a lot of training, thousands and thousands of anastomoses. So a lot of scope time to train a supermicrosurgeon. Now, with this technology, the playing field is level. And also, with the robot, we may be able to break human limits. Why do we need to break well, what's the human limit? Currently, it's 100 micron, 0.1 millimeters. No one that I know of can go lower. But why do we need to go lower than 100 micron? Well, lymphatics are all smaller than that. So lymphatics is currently out of reach. And also, we can do so with minimal trauma. We're getting into the central lymphatics that are in the chest, in the abdomen, and inside the skull. So without a way to get in there without cracking everything open, we will have to do these procedures with a lot of invasiveness. So that's what I see how the robot can help us. And lastly, this is another question that's commonly asked. We get asked a lot, how much longer do you think you can do this? Actually, the chairman of Cheng posed that question to me. He said, hey, Wei, I don't think you can do this for too much longer. And actually, we don't know. We're the first generation supermicrosurgeons, and we have the world's first fellowship trained supermicrosurgeon sitting in the audience. So we really don't know how long, what's the professional longevity, how much longer can we do this? But now I have the peace of mind knowing that, hey, if my hand starts to get shaky, okay, I'm actually done. Thank you.
Doing lymphedema surgery, the first clinic, there's two guys in wheelchairs with their legs stuck out on platforms, and they looked like oak trees. And I thought, oh my God, I hope they're not here to see me. And they were. And how do you avoid that? Because it's so frustrating. You know, you have these 50 patients in clinic that none of them are operative candidates.
But I think, first of all, we need to put, I know we're in an environment that people are sensitive, people are expecting us to not say certain things. But I think still we need to remind ourselves, we're surgeons, we're physicians, we're here to help and treat, we're not here to police. So a great procedure will become a bad and ineffective procedure when performed with the wrong indication. If they have a BMI 40, you try to do these super micro, first of all, it won't work. It won't work. And any surgery that doesn't work, you're hurting the patient. So yes, every now and then, well, it's gone down a lot because usually patients research about us before they come. They usually have a bit of confidence in our ability. So I don't get reported to ombudsman as frequently anymore when I told them you're too heavy, you need to lose weight, or it could be something else. So, but we don't just abandon these patients. We tell them what they need to do right now to get themselves better. And telling them they need to lose weight isn't abandoning the patient. And especially now with GLP-1 agonist, medical weight loss is now a reality. In the past, we can only do bariatric surgery that could be quite progressive for people. So optimize, prepare the patient, and then do surgery.
With regards to the patient that shows up and they have disease, we know the patients who say they clearly would benefit from liposuction. But that transition in the center of your graph, your algorithm, how do you make that decision objective? And I know that feeling.
So that's an excellent question because I made that mistake. So we talked about fluid and solid disease as if it's binary, it's black and white. That patient go from fluid and all of a sudden they're solid predominant. Obviously, it's a continuum. And their patient with deformed leg, really, really bulky, you know those are liposuction. And then they're also patient with a sliver of fat deposit. And by the way, it's a separate question. How do you appreciate that? Well, a careful pinch test already compare healthy side to the affected side already shows you that you can obviously do bioimpedance, compare the muscle mass, tissue mass, fluid quantity, extracellular water, all that, MRI, which will show you tissue and fluid. But usually a careful pinch test, you can already see that. So I think it is a dilemma if they only have a sliver of fat. What do you do? I'll share with you another project that we wanted to pursue. So actually, let me answer that your question first. Earlier in my career, I have a high threshold to offer liposuction. And thinking back, it's me. I was reluctant to do liposuction. So I cover my eyes. And when these patients return, every now and then I see a patient that I operated on 8, 9 years ago, 10 years ago. Usually I realized I had ignored their solid disease because of my blind, at the time, blind pursuit of supermicrosurgery. Because, well, if you're a hammer, everybody's a nail. If you think that you're a supermicrosurgeon, everybody who comes through, you see supermicrosurgery. So I have redone quite a few of these patients. And I saw that back then, I just covered my eyes. I chose to not see their solid disease. So that's what's been happening over the year. My threshold to offer liposuction has gone down a lot progressively. Now, there's still those patients who only have a little bit of fat deposit in the foot. And what we've been hoping to do, and this needs to be an RB trial, is to do Kybella. You need something that's less aggressive than surgery to melt the fat away. But I've been trying to get Elegant to pay for the study. Well, they're not here. But yeah, that hasn't been successful.
Hi, the Paul Dingo Lab team, please go to the sim center to set up now, and then we can get them quickly and come back to listen to Baskaya, Professor Baskaya's talk. Yeah, Paul Lab team.
What are we to do with this? I don't know.
And after the morning talk, we will have a one-on-one practice with the expert instructor session. Now we have a double head microscope, so I already request the instructors to sign up the first round. So we have Dr. Key, Dr. William, Dr. Shishi, Dr. Kyle, Angela, Wei Chen, and John and Nielsen. They sign up for the first round. So we will have 30 minutes for one session to practice with the instructors from 10:30 to 11:50 before the lunch talk. And if now I may not have time for, I try to let you guys to sign up a space. And if you don't have a space, you can practice in the other room also. And Sam and I, if the instructor, you don't have enough time, Sam and I and Kylie and Aparna, yeah, and Ethan, we can jump in and help you.
Thank you. So yeah, so we'll have this sign up and it'll be a good morning. Our next speaker, Dr. Mustafa Baskaya, is an extraordinary surgeon, microsurgeon, educator, great doctor, and is an excellent microsurgeon. And I think the very first micro course was us. 10
10 hours ago.
Yeah, 10 years ago. with Aaron Whelan and you and me. It was amazing. So they've since branched off with little different indications for micro to their own course, which is fantastic too. Dr. Baskaya is a great guy to know. I love working with him. Typically, the way he asks for a consult is, I have a free flap I need you to do. And I never question, I just show up and do it because he's always right. And it's great. It's excellent. I have to do very little thinking. So thank you for coming on your Saturday and spending time with us and talking about microsurgical applications to neurosurgery.
Thank you, Sam. Thank you. I feel the same. Having you next to me is always assuring. And thank you for having me. Thank you for coming. Sorry, I have no conflict. I don't like this kind of slides, but this UW is a very strange place, so I have to say it. So, and special thanks to go to Sam and plastic surgery team at UW. When I came in 2006, first person I met in the hallway actually was Uncle Mike. Is he here? Oh, okay. Uncle Mike, and I love him. I fell in love with him that moment. Okay, so great guy, and then department led by him now is led by Sam. Is a wonderful department. As to me, the best team, surgical team at UW, in Wisconsin, state of Wisconsin, probably in the United States and in the world. And they always get wonderful residents too. I don't know why we don't get those residents. They are not here, right? So they're going to write me up now. Dr. Baskaya said this, they're horrible. So, yeah, always I don't know how you guys do it. Very smart, wonderful residents, hardworking. And to me, plastic surgeons are the surgical psychotherapists. Because what you do, you don't only save the extremity, save the patient's life, patient's fingers or appearance or whatever, but these are social things, right? You are psychologically treating those patients too, not only medically. And plus, you are psychologically treating the other surgical disciplines like neurosurgeons. Okay, so, I have this, I cause this bad wound infection, bad wound decence, call Sam, call Brian, call Katie, Jackie. So it's having you guys around, plastic surgeons, is a big relief for neurosurgeons like me. Okay, so thank you very much. Thank you for what you do. I always appreciate, and tell you the truth. First, when I was in medical school in Turkey, I want to be plastic surgeon. Sixth year, I saw what they do. Plastic surgery is very, even in those years, early 80s, was very advanced in Turkey. I love it. I said, I want to be plastic surgeon. Then second rotation, I went to neurosurgeon. Like every Turkish man, I fell in love with the other discipline. So thank you, and it's a great pleasure to be here. And thank you for coming on Saturday morning and listening this guy with a strange accent. And my vocabulary is limited to 10 words. Okay, 3 surgery. Other 3 anatomy. Other 4 starts with the F. I don't want to say it. I'll be in trouble. There's no hospital administrators here, hopefully. I mean, so why do we bypass or microsurgery? There are so many other microsurgical things. We do microsurgery. Sometimes Dr. Wang used the super microsurgery. I say ultra microsurgery for brain tumor removal. That's healing that less than 1 millimeter vessel or vein, artery, whatever nerve away from the tumor. That's ultra microsurgery. Clipping the aneurysm, treating these pathologies are microneurosurgery. But mostly microsurgery, when you say this, you indicate the vascular neurosurgery.
and most of the time that's a bypass. Why do we do bypass surgery in neurosurgery? Okay, so we do for several occlusive diseases. Okay, so that can be atherosclerotic, stroke, or stroke-like symptoms. You occlude one of the cranial arteries. You may need to do bypass, or condition called moya moya. Moya moya means puff of smoke in Japanese. Is a strange. We don't know the etiology of it. What starts as not genetic, not hereditary. Initially described in Japanese population, then we thought is other Asians, and now is all races of you can see, and it's strangely intracranial vessels become over time diminutive, eventually occluded, and you develop these extreme collaterals, and that gives the impression of puff of smoke in angiogram, and Japanese call it puff of smoke, moya moya. And we also do bypass for flow replacement. So flow augmentation, there's enough flow. There's not enough flow. You are augmenting, giving more blood to the brain, blood supply to the brain by providing different channels. So flow replacement is you have a pathology you cannot treat with the conventional ways, like a giant aneurysm. You cannot clip it. They cannot put the stents. They cannot put the coils. And you have to take that out. You have to trap it. We call it trapping. So you clip proximal, clip distally, and you provide bypass. And or complex tumors, like skull-based tumors, encasing these arteries. You cannot remove it, and it's threatening the patient's life. So you have to replace that flow by providing the bypass. Sometimes you cannot trap, so you can trap this aneurysm. You can put clip here, you can put clip here, but you cannot trap this aneurysm because there are so many important tiny perforators going to the internal capsule in this segment from the aneurysm now. This is a congenital aneurysm in a 6-year-old boy. So you cannot trap it. What you do proximal occlusion, you do bypass, and over time, there's no demand anymore. Those perforators will stay live, but the aneurysm will go smaller and smaller and smaller. And the perforators, due to the demand from that region of the brain, they will stay alive. And we call it flow diverting bypass. And sometimes for these pathologies, you don't know what you're gonna end up doing it. This is thrombose, giant ophthalmic artery aneurysm. I need to open the aneurysm, do thromboendarterectomy, and check whether or not I can clip this aneurysm safely. If I cannot, I have to have some other option, that's bypass. Even if I can clip sometimes, that cross-clamping takes more than 20 minutes, you are subjecting brain to ischemia. So what's gonna happen? So you do prophylactic bypass, and during that time, you can freely work around and you don't worry about timing, rushing, and you use neuromonitoring, all that stuff, but it still is not good enough. So you do this prophylactic bypass to buy time, basically. And these are the common types. Some of them, I don't know, some of the abbreviations make sense, but the superficial temporal artery, middle cerebral artery bypass is the most common extracranial, intracranial bypass. Occipital artery second. Sometimes we use vertebral artery, occipital artery to posterior inferior cerebral artery, or occipital artery to vertebral artery. And we do in situ bypass too. You have vessels, you have a pathology, you remove that tiny vessel and bring the other vessel right there next to it, you anastomose. You don't need to do STA, you don't need to do that. And that small vessel, you can just do middle cerebral artery to middle cerebral artery, anterior cerebral, or posterior inferior cerebral artery to posterior inferior. You have to do sometimes site-to-site bypass. We call it site-to-site bypass. Sometimes we need interposition grafts. You need higher flow. We use radial artery, and the saphenous vein is the most common. They are the most common two arteries. Sometimes you don't have these. And one plastic surgeon taught me this artery. Dr. Keen, when I came here. Patient didn't have saphenous vein. lost the radial artery from multiple canalizations. And he said that there's this artery we use sometimes, the cardiac surgeons use, and I used it. Beautiful, long incision, all that stuff, but I used in 2 patients and worked very well. It's like almost same size of the radial artery. And one case, Sam and I'm going to show it. We had to use the cephalic vein, and more, not always, but in this region of the United States, we get these patients. They are sick. They don't have this nice conduits. They don't have STA. They don't have this. So you need to evaluate these factors very well, and then always very helpful to interact with the other disciplines like plastic surgery, vascular surgery, cardiac surgery. They know more than we do, neurosurgeons do, and you guys deal with this every day. You don't. This is bypass surgery is not, even I do most of the bypasses here. I don't do once in a month, sometimes once in 2 months, sometimes 2 in a month. It's not like every day you guys do. So it's good to interact, and then I learn a lot from my plastic surgery colleagues. When I present the cases, I'm gonna mention what I learned. So these are the most common pathologies. We use bypass procedures, and this is how I do. Okay, so this is superficial temporal artery to middle cerebral artery bypass for atherosclerotic disease. I will use frontal and parietal branch of the superficial temporal artery. This is the technique I learned in Japan. I like to start the bypass under the microscope, even skin incision, right away, small to high magnifications, and use all techniques, bipolar technique, low intensity Bowie technique, or dissection, sharp dissections. And the most important thing is this conduits. They have a very thick adventitia and soft tissue around. You have to clean them certain segment so you can do bypass. Another concept we do this fish mounting. After obliquely cutting the donor artery, we fish mount and we create like a cobra head. So it becomes a much wider anastomosis surface. We neurosurgeons believe that increases the chance of patency after the bypass procedure. That's the STA. I'm going to do the same thing with the parietal branch, frontal branch. So I'm going to hook to the, if I can, distal branch of the MCA on the frontal side and distal branch of the MCA on the temporal side. So I cover both territory. And then you need to find a good recipient artery. That's not always possible in moyo patients, but atherosclerotic patients you can find. Like that's again showing the fish mouth, and you do the bypass, and you guys do, and this is the recipient artery. You have to prepare it very well. This is very high magnification. You need to clean the pia. You need to clean all that tissue to free this certain length and bring it up, put the ruler under so you can estimate the arteriotomy you're going to make depending on the donors. And then again, doing the other recipient preparing and doing the bypass. The rest is I use interrupted sutures. Some neurosurgeons do running. I found the running sutures are difficult because you cannot tighten them. You have to tighten later. And when you tighten, you can break it, as you know. These are 10-0, sometimes we do even 11-0, 9-0 sutures. You can easily break. And then the rest is anastomosis part is not that difficult, okay? So we like to do beforehand because in neurosurgery, different from the other disciplines, time is important. You are subjecting this patient, so any suture you can put before. I put the toe and heel sutures before, and then I do the recipient artery sutures. And large arteriotomy is the key, heparin irrigation, and vasodilators like papaverine or sodium nitroprusside prevents the dry. When they become dry, they get spasm, especially intracranial artery, so prevents that kind of opening. And then the toe, heel, and then the side, and then we like to do most difficult side, the side away from us. This is an easy case. This is right on the surface, and the recipient artery configuration is so good. It can give you, like, you can turn this way, you can turn this way. You cannot do that in every location in the brain. And that causes extreme difficulty sometimes in the deep. So you see that cobra head, the nice anastomosis surface, although there's a size mismatch, that large arteriotomy and the cobra head, that fish mounting helps to overcome that problem. And then we do the other side. I'm going to skip that. And we have a nice technology. I don't know you guys use now, Sam, but ICG green, industry green video angiography. STA is here. Recipient artery, everything is flowing nicely, not retrogradely, antegradely. We are golden. We are done. And then this is my principles, and some of them I learned from my plastic surgery colleagues. Some of them I learned from the cardiac guys. For example, Wisconsin broad. Did you guys know there's such a thing? Wisconsin broad is you use patients' own heparin, own blood, mixed with the heparin and verapamine. And I learned from this from a professors of radial artery harvesting, PA, physician assistant, who harvested 20,000 radial arteries. To tell me this is an anecdotal note. This is evidence-based. According to all that nonsense we talk, evidence-based, this is not anecdotal. 20,000, and he said that he came up with this formula. He never had problems since he used this. I trust that guy. So that's why. But the principle is the same. Cover them. Microscope light dries the arteries and cause vasospasm. And I don't like dilating the radial artery. Some neurosurgeons do, but Dr. Benz and the Mark Keen told me if you dilate, you paralyze the vessel wall. It's not good. Just keep it like it is. Put in the blood. I learned all these techniques from my colleagues. And these are the flow augmentation bypass, couple of examples for Moya Moya. And then there's a technique, we call it indirect bypass. It's called encephalodural synangiosis. It works almost always in Moya Moya patients, but it takes 2-3 months to get working. So what is that? You put the one STA branch over the pia, suture to the pia, open the arachnoid. Over time, due to that demand, Moya Moya patients developed collateral sprouting, but it takes 2-3 months. So you have to do one immediate bypass, direct bypass, and or indirect. But some surgeons think that the bypass is so technically difficult. Neurosurgeons, they don't do direct bypass, they just do IDAS, indirect bypass. I do both, and I also put a burr hole in the frontal for anterior cerebral artery territory, and put the pedicle pericranium onto the brain surface. I opened the arachnoid, roughened the arachnoid. Uncle Mike is here. I have to be careful what I say. Sir? So this is a Moya Moya patient presented with the basal ganglia hemorrhage. So Moya Moya patients can present with ischemic stroke or hemorrhagic stroke. Ischemic stroke due to the hemodynamic insufficiency. Hemorrhagic stroke due to those extremely dilated perforators. They dilate, and a little hypertension can cause burst, and you have this. This patient moved from Japan, started living in the United States, and had the other side done by the Japanese neurosurgeons. You see nice STA, MCA bypass, and now presents with the right-sided hemorrhage. So this is the same thing, same principle. In Moya Moya patients, I don't like doing double barrel bypass because it can cause hyperperfusion bleed in the brain. That's another thing we worry about in the brain. You don't want to push too much. And sometimes in Moya Moya it's very difficult. This is the IDAS part. See, I open the arachnoid, I am suturing to the arachnoid and then the dura. Over time, 2-3 months, you do the angio, this all sprouting starts. It's amazing. But that works mostly on the Moya Moya patients. You see the bypass there, open. And then for ischemic diseases, like the first case I showed you, I like to do double barrel. I like to use both. because ischemic patients' demand is higher than moya-moya. Collateral channels not develop as much as moya-moya disease. And this is the one, we did it. Same thing again. You see both branches, STA frontal and parietal branches coming here, anastomosis. This patient was getting TIAs constantly every day, initially after the stroke. She's living perfectly normal. And this surgery really doesn't take more than 7 hours. And sometimes, like I told you, there's nothing available. Nothing available in the head. So this is atherosclerotic occlusion of the common carotid artery. There is no common carotid artery on the right side. There is no STA. There is no external. Some collaterals from the right side, some collaterals coming from the posterior circulation, and patients get TIAs, strokes every week. And this guy is a homeless guy, and not normal though. He doesn't behave normally, but he doesn't get enough blood to his brain. There's a reason for that. So neurologists try this medication. This is not embolic phenomenon. This is not embolism from the heart or the great arteries. This is a flow phenomenon. So you need to but what am I going to do? There's no STA. There's no common carotid artery. You have to be creative, right? And I look at the literature, how people did it. I found in the 80s, people did the Bonnet bypass. Brought to saphenous vein, radial artery won't reach, from the contralateral STA trunk, now in this case left, and make a groove on the both frontal bones, bring to the right MCA, suture it. But it's done in the 80s. After that, other techniques developed, people stopped doing it. And this was a perfect case, but I haven't done it before. We studied, and you need to pay attention. So I found the common trunk, and sometimes one note, it goes to, I don't know who was, but I think it was Dr. Benz. I had a problem finding the STA trunk in one patient. I called Dr. Benz. He came, he's like, have you ever opened the parotid? Yeah. Okay, I opened the parotid, found the STA trunk, beautiful, 2 minutes. So that's why you need good people around you. And this is the big incision, bifrontal. And you have to create a groove. So we are opening the right side because intracranial problem is on the right side. So craniotomy. And the cardiac guys harvesting you need to get a long segment of the saphenous vein because it's very hard to estimate the exact length coming from left STA trunk to here. So as long as you can get, and the Wisconsin broad, and then you open the brain, and this is different now. The superficial bypass is okay. Artery is on the surface. So in this one, you have to go to the proximal MCA. You have to open the Sylvian system and get deeper and inspect these vessels and decide which one you want to use as a recipient. You look at this vessel, you see hypoperfuse, it looks white. That's the problem, but it's still alive, it's not thrombosed. You Doppler, you do ICG green, is alive, but it doesn't get enough flow. So, and this is the good bypass for trainees because there is no time concerns. This is STA trunk, and you go different from the other bypasses. You have to do proximal bypass first because you want to estimate the true length of the saphenous vein after retrograde the field with the blood. Large arteriotomy, bring the saphenous vein, and good train chief resident or fellow level, so they can do this. 8-0 suture, 10-0, 9-0 won't pierce the saphenous vein, so you have to use the bigger and stronger needles because 10-0 will bend and broke. So then do that, and we'll finish that. And then see that I have my chief resident did the groove on the frontal lobe because if you put the right over the bone, scalp with the edema, it's going to compress and it's going to occlude too. So you have to create a space, and that takes time. It's not easy. Then you have to anchor graft so to avoid the twisting. I anchor with the 7/0 sutures to do skull. Then you have to do this is now my part. You can estimate from my tremor, right? Old man tremor. So then this is the MCA, M2 branch, okay, the large arteriotomy. And then hook to do that, okay? Again, you have to use 8/0 or 9/0. 10/0 is too much, too fine for this. You can use running, but I'm doing interrupted at almost same time. And once you are done, you have to get the air out because you did the distal proximal bypass first. You don't want to push the air into brain. And that's nice. And then we're going to suture that hole. After that, now we're going to see the end product. So this is, I was referring to see how it is, how it's pinky now. The same artery, different magnification. Okay, that's the brain. We're going to close that part. And this is the graft. Okay, crazy. This is my first bonnet. I have done 2 more after that. Now I have the largest series thanks to the people of Wisconsin. So they lose their vessels early. This is the entrance. Most they've done like a 2 or 1. I have done 3 and worked very well. But this is the desperate situation though. There is no other way you can do. Okay, this is not everyday bypass for neurosurgeons. And this is him. You know, 1 year after he found the work, now he thinks straight. It's like 6 years now, he's normal. And this is what it looks like in the CT. See, and he's bald like me, but you can still see his graft like this. He said, first thing he told me, in the streets, Dr. Baskaya, nobody come close to me. I scare everybody. He was happy, you know, he was living in the streets first time, first year. So this is another story. You know, one thing doesn't work, you always try to find another one. This is a typical example for posterior fossa ischemia. You see this brainstem strokes and bilateral cerebellar strokes. Am I doing okay with the time? Sam? Okay. So this is, patient is not getting enough blood because both vertebral arteries, one is completely occluded, one is super high grade stenotic. And collaterals is anterior spinal artery, and this is the thing, and occipital artery, also collateral on one side, the other side, there's no occipital artery. See, this is leptomeningeal collaterals to the brain. So I said, I cannot use this occipital artery because occipital artery is providing blood. I don't want to take that blood away, and I don't know what the consequences will be. So I decide to do vertebral artery, V3 segment, we call it, right over the C1 lamina. Interposition graft, radial artery, vertebral artery to the posterior inferior cerebellar artery. Right? It's because seems like there's a healthy segment. This is the V3 segment, we call it right here. If I can do vertebral artery and bring the between vertebral artery and pica radial artery interposition graft, is perfect, right? But sometimes things don't go perfect. So this is the way we do it. We map the occipital artery is because I want to protect the occipital artery. I don't want to cut. But same time, as a backup plan, I may have to. So I prepared the occipital artery in that, and then I don't know who harvests this. This can be Dr. Benz or Sam Yu, I don't know. So this is the cerebellum. This is brainstem. This is spinal cord. So in the deep hole, we're gonna find the recipient artery, posterior inferior cerebellar artery. And first do the distal bypass. That's normally we do if other than the Bonnet bypass, okay? Vertebral artery is occluded. We're gonna find that. We're gonna prepare the radial artery like we did. And this is a very deep anastomosis. You are deep in the right here, and it's so difficult. There's not enough space. You have to use your fingers to reach. And anyway, we do it, take the things, and see is working. Nice, it's working. So the graft is filling retrogradely. So then next we're gonna do the vertebral artery. Okay, I open vertebral artery. Is very atherosclerotic. I didn't predict that. So I did the endarterectomy. But anytime you do something in vertebral artery different from the carotid artery in the neck, it gets thrombosed. I was hoping it won't this time, but it did it. And I did the proximal bypass. I open, graft is not filling. I knew it is vertebral artery. And once I undone the this proximal anastomosis, graft start filling again. So that confirms, see, it's not coming from the vertebral artery, is thrombosed. It's dark. So what am I going to do? I have only occipital artery, but that's leptomeningeal collateral, but I have to take a risk. I said, okay, screw, I have to do it. I did it, end-to-end occipital artery anastomosis. And the problem with the occipital artery was also very diseased. But luckily, we already have the radial artery, find the disease-free non-atherosclerotic segment, did the end-to-end bypass, but there's a size mismatch. You can come over that with the different sutures. I'm going to show you another way. And end-to-end anastomosis. Now is the graft is going to fill antegrade beautifully. So radial artery interposition graft between occipital artery and posterior inferior cerebral artery. And this is him. This guy wasn't able to get up and eat. Anytime he sit up or get up, he will have stroke-like symptoms because he was hemodynamically, his posterior circulation wasn't getting enough. He had to eat 2 weeks. Neurologist kept him flat. And then right after surgery, he started sitting up, getting up because he was getting blood now. These are the bypasses we use, flow replacement for the aneurysms we cannot repair surgically or endovascularly, or traumatic iatrogenic intracranial injuries or skull-based tumors. These are the typical case. Look at this fusiform aneurysm. They try to coil and put stent on this. Each session 12 hours, 24 hours, hour 3. Super good experienced endovascular colleagues, they couldn't. And there's only one option left. Do the bypass, trap, give her a new conduit. So this is the thing. I'll go. Okay, this is how we pass the radial artery from head to neck with the pediatric chest tube. Have you done this? And then again, radial artery adventectomy. And then we're gonna go first to the distal bypass. This is like the other case. This is MCA branch, deep in the sylvian fissure. You see the brain retractors here. I have to hold the brain. If each pulsation comes and then it prevents you to make your surgical moves. Radial artery graft again. And now she had a very high carotid bifurcation. I cannot use, ideally we like to use external carotid artery. I cannot do that. So I have to do common, but her common is also very atherosclerotic. And I learned from cardiac guys, they use aortic punch. And then but you'll see how atherosclerotic is her vessel. Even that wasn't enough. After aortic punch, I had to do more resection of the wall. So it's a good elliptic shape. And these are the, initially I start with ATO, but ATO's, some parts couldn't pierce the carotid artery because of the atherosclerosis. I have to use the 7-0. I felt like I am cardiac surgeon at that point. Cardiac surgeons, they stop at the 6-0, 7-0. They cannot go beyond, and they use loops. We use microscopes, right? We are microsurgeons. Yeah.
inside out. That's really important. So if you take see how he's going from the inside out. So any those plaques.
Yeah.
If you go from the donor vessel to the recipient vessel, you're going to push those plaques off. This is a beautiful.
The punch can sometimes push the plaque off too.
Yeah.
Obviously very meticulous about making sure that edge is freshened up. That can sabotage the whole.
Yeah. Excellent points. So now I need to find the area. I have to put the trapping clip distal to the ophthalmic artery. We are doing this surgery to prevent blindness, right? She's having the optic nerve compression. So I did a skull-based technique here. I removed the clinoid process, anterior clinoid process, found the ophthalmic artery, and put the distal clip. I'm sorry, I'm skipping this. Distal to the ophthalmic artery. This is a big aneurysm clip. Now I'm occluding proximally. Okay, I'm gonna take the clips, temporary clips from the neck, and in the brain bypass, there's a competing problem. So if you have two systems competing each other, bypass will get thrombosed immediately. So you have to do some kind of temporary clipping until you complete the other bypass in the big high flow bypasses. So now I have to find another good spot so I can preserve posterior communicating artery and anterior choroidal artery. So then that's called trapping distally, and I'm going to puncture the aneurysm. So this is because I have to decompress the aneurysm, and it's not enough. I cut. That's the residual flow. So now his aneurysm is open, decompressed, optic nerve is happy. Okay. Then we walk her up. This is the ICG green. Bypass is filling. All the vessels distally filling. This aneurysm is gone. And this is Sam did this case, and everything worked beautifully. You see the radial artery graft coming from common to the middle cerebral artery, and this region is gone, but blood is coming from radial artery distally to the anterior cerebral artery, and these are the showing that clips what we use. And this is post-op day 1, and that's the after. She lives normally. Still smoked though. Still smoking. She didn't learn. And this is another famous case, thanks to Dr. Benz and Jackie. Jackie is here. They will remember this case. 10-year-old boy with this severe headaches, recent onset. You see the vasogenic edema in the brain, and this is partially thrombosed aneurysm. If you look at this aneurysm, you know, it's the fusiform aneurysm. You cannot clip this, you cannot coil this, you cannot do endovascular occlusion. You can simply trap sometimes if there's a good collaterals, but when we did the angio, there are no good collaterals either. You cannot just simply trap endovascularly or surgically, so you have to do some bypass. So in the head, this is the aneurysm showing, you know, it's partially thrombosed. And in the head, we have like I said, we can do inside to bypass. I can bring two anterior cerebrals together, side to side, and then trap the aneurysm. But if you look at this, they are part ways. They are not going to come together. It's not, and they are perforators. You cannot just pull them together, and you cannot take those perforators. You're going to give them a stroke. So that's why that although it's option, until I explore surgically, I wouldn't know. The other way is like I did STA to A3 bypass and trapping with the radial artery and saphenous vein. And Dr. Benz and his whole plastic surgery team for 1 week, we worked to estimate the true length of the radial artery we need from the STA, measured this, did this. You remember, Dr. Benz? And normal kid, just headaches. And we did it. I explore everything, STA, we did the cranial. This is an interhemispheric fissure between two brain hemispheres. That's falx, you see. This is the falx. This is the left hemisphere. I need to find the recipient and explore. I am finding it. And finding the aneurysm. I did the baseline ICG green. There's temporary clip to test the retrograde flow. This is like a balloon test occlusion. There's no retrograde flow. So I'm confirming that he's not going to fly if I just simply trap. And then, I'm sorry, I'm boring you with these neurosurgical concepts, but then I decide to do bypass, radial artery. Jackie and Dr. Benz prepared. And we measure like a 60, we estimated, I believe, 16 centimeter. Dr. Benz is so happy, arm is cracking the jokes while I am pooping in my pants. And what happens? It turns out 11 centimeter because it shrunk. Oh man. And then pooping increase, becomes diarrhea, and oh God, what am I gonna do now? So it's impossible. So, then I get the idea. This is, instead of STA trunk, maybe I can use frontal branch. And she had a good frontal branch. So then that will reduce the length I will need for the interposition graft. But that's very small artery, okay? So that wasn't something we were thinking. And plus, during that pooping sessions, I got nervous and I cut the artery. I had to repair that graft. Okay, that's my fault. And we do the bypass again. This is extremely deep bypass, and this case was Azam Ahmed's case. He didn't do this kind of bypass before, so he asked me to do it. Azam is assisting me, but still not enough. You know, there's a brain retraction on the falx. It's very deep, very narrow corridor, and then we did it, and then we're gonna now harvest the frontal branch, as you see. And now, but the problem is very small artery, and there's a big size mismatch. And then I use the dilators, whatever you guys do, everything you guys do, I did it voodoo. And then I came to my mind, if I obliquely cut and make the radial artery smaller and suture that part, so I cut this corner, I made the radial artery smaller, you see this? And then its size is okay. So I'm not a creative person, but God helped me at one time. I think this, so it's good. And then we did it, and worked perfectly fine. And aneurysm is gone. You see, it's filling. And I was so happy. She is extubated. CAT scan looks good. And I saw Dr. Benz in the hallway, Children's Hospital. And he said, before he said good morning, you know, normally he's a very cheerful person, right? He said, Mustafa, what did you to him? I said, what happened? I heard he's doing fine. No, I went to his room. I said, good morning. He heard his reaction. This is a nice kid. Never you curse. He said, F you, Dr. Benz. Because he woke him up to see how he's doing. And he was frontal. He had a frontal lobe. All right? He had a frontal edema, right? You retract all that. He was so upset. He thought he did it, not me. He was holding Dr. Benz responsible. Of course, you know, we neurosurgeons and patients comatose, we say, oh, he's okay, he's okay. I said, Dr. Benz, don't worry, he's okay. And then in 2 days, he cleared all his frontal lobe symptoms, and he's doing perfectly fine, Dr. Benz. I don't know if you saw him, you still see him. This is the graft, you see the radial artery, and this is the thing we do. And sometimes we do dissecting aneurysms. If I have time, I like to show this. This is a patient comes to Moderator Hospital, cardiac arrest, bad subarachnoid hemorrhage, the resin pus to ventric, another cardiac arrest. So we transfer him here, did the angio. This is a fusiform dissecting aneurysm, dissecting dilatation of the origin of the posterior inferior cerebral artery from the vertebral artery. Morbidly obese, and we did the MRI, so he didn't sustain any ischemic brain injury. That's good. Endovascularly, nothing you can do. They have to sacrifice this one. This is a big vessel. If you sacrifice, you can get a cerebellar stroke, but most importantly, brainstem stroke. So even if he has a chance to recover from that, you are taking that chance. So we discuss, and I discuss with the family, let's give him a chance, and we prepare for the bypass. This is, again, very difficult bypass, and there's no occipital artery. He's morbidly obese, neck is very big, and this posterior fossa, look at the bone. This bone is very thick. You have to do very wide craniotomy here, so you have an angle to look at this region. This craniotomy itself took 3 hours. Normally, it will take like a 30, 40 minutes. It's thick bone, this thick. And then Sam is harvesting the radial artery. They are doing beautiful job. Again, their plastic surgery side is always cheerful. Neurosurgery side is grim. They don't talk. We don't listen music. We're like depressed. And cursing is good. Cursing, I do that very often. Constantly cursing. Why did this happen to me? Call God. Why is this patient like this? And finally we got it. And Sam said, "Hey, sorry, man, radial artery thrombosed." Oh, fuck. What's going on? What can we do? But we prepared the leg, if I remember correct. So I said, "Oh, don't worry, we can go to the leg." But then he said, "I have a cephalic vein here, beautiful. It's as large as saphenous vein. Golden. So you need smart guys, okay?" So Sam got me the cephalic vein, big size mismatch, but at the end, I'm sorry, I'm speeding up. It's going to look like this. Vertebral artery to pica, this is a big pipe. You look at that saphenous vein, is gigantic, okay? It's huge, but it worked. And there was little kink. I corrected that. In the intracranial bypass, we worry about kinking. Kinking causes obstruction. And little thrombosis will trigger big angiogenic factors, all that stuff. So we did it. And 13 people, 14 people were watching, all these guys, international fellows, making me more nervous. This is the graft. 2 weeks, he started waking up. 3 weeks extubated. He didn't need even tracheostomy. This is rehab. This is after. He's alive. Grade 5 subarachnoid hemorrhage means meaningful survival. Forget the disabilities, less than 5%. So this guy is a miracle. And he lost weight, you see, good. But he's been living. So infectious aneurysms, you can do something. In this case, interesting. The endocarditis, infectious aneurysms, they are very difficult to treat. You have to sacrifice the vessel. But this patient is left-handed, and this is her right side, but the opercula. So if she recovers, if you sacrifice that artery, you are giving her a stroke. Her speech may not recover. So, and there's no STA. There's nothing. And these vessels, you cannot do radial artery. I'll show you. Okay? Very, very bad problem. And this is the hematoma. Look at the brain. Look at the pus coming from the aneurysm region. And aneurysm is coming from one distal branch and then 2 branches like that. So that 2 branches, submillimetric, super bypass, super microsurgery we need. So what I'm going to do, I found another artery passing by. I'm going to do inside to bypass. I'm going to bring that artery to end to side and preserve the continuity of the normal artery, hook the artery I cut to there, and then I'm going to do another one end to end. This is like we measured like a 0.7 millimeter or something. So inside to bypass, working fine. And then we're going to cut the aneurysm now. This is that infectious aneurysm. And the other part, I'm going to do end to end. This is not that difficult. It's right there. You are cutting one branch to another one, suturing. So did very well, actually. Recovered. Very poor subarachnoid hemorrhage again. Poor prognosis, but she still has having some endocarditis issue, but she's living near normally. Okay. Skull-based tumor, same. You remove the tumor, you have to replace. So this is what we did. Okay, we removed this big tumor. This patient is from California. Put the fat and did the graft from common carotid to MCA because tumor was encasing the carotid artery. And again, same thing. Traumatic aneurysms, you replace. This is flow replacement. Flow diverting bypass, same thing. Same principles. Okay, you cannot sacrifice, you do flow diverting. And sometimes, like I said, we do prophylactic bypass. And you clip the aneurysm, but you need time to open the aneurysm, get the thrombus out so you can clip. If you cannot clip, bypass is there, already done. So you guys know this. This is very cliche conclusion, but to me is the most important thing is mental preparation and having the multidisciplinary approach and learning from each other and going to the lab. You have to go to the lab. What you do today, what you did yesterday, do that every day. Do you know how I calm myself? I have an office microscope. Anytime I feel like I'm going to kill somebody, I go to office suture. It's the best way. Okay? Anytime you guys know, or go to the cadaver lab. We have a cadaver lab. Dissect the cadaveric brain. It gives you a, meditation. This is what we started in 2006, go to 2018. Now this Abdullah brought to this level. This is every resident does. And I ask my residents, unfortunately, it's not mandatory. We cannot say mandatory word anymore. It's voluntary. If I say mandatory, I'll be in trouble. But fellows, for international fellows, I can say it is mandatory. So they do it. We do also offline training, and Abdullah and myself, sometimes we travel, go do these courses in the underdeveloped countries. We develop a way of doing that, and we publish. So we open these small labs in the underdeveloped countries, help them. Abdullah buys, we buy microscopes, send them, stereoscope actually, and with the light source. And sometimes we buy these old OPMI-1 microscopes. And we got this fellow from Nigeria and Chad and Guinea. We trained them here a few months with the same microscope we bought for them, disassembled the microscope, put in the luggage. When they return home, they go with that luggage, assemble back, and they use in the surgery, real surgery, and they save lives. Okay, so this is like a spreading, right? This is spreading of microsurgery. And you guys, I know you do the same. You travel all over the world. So at the end, go to the lab because you hear, you may forget. You see, you may remember some. But if you do, you understand better. Okay? But now is more than 380 fellows, over 18 years now we have. But please listen this guy. Do you guys know who is? This is Jiro. This video taken when he was 85-year-old. He has an omakasen sushi restaurant in a small restaurant in the Tokyo train station. I'm sorry, I'm going over. So 10 seats. You sit here